Hello. Hello. Yes. So good morning as well as good evening to one or all. Myself, Mr. Madhu, representing Inovine Conferences, welcomes all distinguished guests, dear doctors, scientists, educators, colleagues, friends, ladies and gentlemen. As we completed day one of the conference yesterday, today we'll be going with remaining speakers. Meanwhile, we ask all the participants to keep mute of audio while speaker is giving his or her talk. If you're having any problem with the uploading of PPT, you can send to mention mail ID or WhatsApp number. We can play behalf of you. We truly value your presentation support for this conference. Thank you so much for joining, for your attention. Now, I would request Dr. Ravi Umpirala, Jiva Therapeutic from USA to start with opening keynote speech for day two.
I thought we were starting at 6:30 India time.
Yes.
Yeah,
It's almost.
It's 10 minutes more.
Yes, okay, sir. No problem.
Yeah. And should I update? Should I load my slides and show them from share my screen? Is that how it works?
Yes, sir. If you're having problem with uploading PPT, you can send to me immediately.
I have sent you. I have sent to the conference address.
Yes, yes. Just be. I'll be checking. Hello. Yeah,
Hello.
sir. We didn't get your PPT.
I sent to Ishanvi address.
So just when we came to know that you didn't.
Oh, okay. Wait a second.
Yes, sir. No problem, sir.
They have been sent as to Diabetes Congress, Inovine conferences. Okay, anyway, I am trying to share the screen so that we can show it from here. I'm sharing the screen. Are you seeing?
Yes, sir.
Okay.
Just you can enlarge it.
I will.
Yes, yes. No, it's fine, sir. Yes, sir.
Yeah,
It's time.
thank you. I would like to start with thanking the Inovine conferences for giving us this opportunity to present this keynote lecture. And also I want to thank all the very renowned physicians and other scientists who are attending this conference. So particularly this talk is focused on changing therapy. So I really am very thankful that quite a few physicians are present here. So in the in the talk title, originally when I submitted, it was a critical role of endogenous insulin secretion in type 2 diabetes therapy. But I added pulsatile because that is actually the main focus here. So I would like to start with the overview. I know many people have presented the overview, but I want to highlight a few things. The main feature or the symptom of type 2 diagnosis is hyperglycemia. Usually the onset is around 40 years, plus minus 5, whatever. Pre-diabetes is symptomatic with a hypertriglyceridemia. And another aspect that is very critical in the diabetes and its course until death is cell starvation, and I will go into that later. I want to particularly emphasize that aspect. So there are many aspects to why the sugar is high in an individual with type 2 diabetes, but the overwhelming reason is the gluconeogenesis, which is essentially sugar that is being pumped by the liver into the system to ensure that all organs have sufficient glucose for energy. So the root cause for this gluconeogenesis, we'll look into that, but there can be many more reasons than what I am presenting here. Pulsatility is one aspect of the insulin secretion from the pancreas and its pulsatility. HPA axis is involved in many different ways, and circadian rhythms and vagus nerve are cannot be ruled out rather. So the hallmark of type 2 diabetes is the islet cell beta cell death or malfunction. It is usually figured out by using C-peptide for type 1 or type 2 and monitoring the insulin and various other tests. We are going to look at influence of secretagogues and other type 2 medications for this, and the cure is probably the best, one of the best solutions is stem cells. There is also leptins and leptin resistance involved, adipose signaling is involved, fasting and irregular feeding is involved, other imbalances and hormonal aspects may be involved in type 2 diabetes. So the current therapy right now is biguanides, and everybody seems to be loving metformin nowadays, which has fallen out of favor for a long time in between. It's almost more than 100 years old. And then there is the TZDs, PPAR gamma activators, DPP4 inhibitors and GLP-1 agonists. They are clubbed together for a reason because they are functionally, actually DPP4 inhibitors act on the same cascade of the incretins. Sulfonylureas and meglitinides is another old drug, but I think that is what we are going to look at more here. SGLT2 and alpha glucosidase inhibitors. These are basically looking at the input side, which is the alpha glucosidase, and basically trying to reduce energy glucose uptake, and SGLT2 to excrete glucose. Then we use exogenous insulin, which is very important in this. Now, if you look at a type 2 patient, usually when it is diagnosed, most of them may be, it won't be surprising if their A1C is more than 9 or 10 or even 12. And so we are looking at something like 5 to 6 percentage points of A1C higher than supposedly the normal level. And if you look at biguanides, they are less than 1.5% reduction in A1C, SGLT2 less than 1%, EZD is less than 1.5. GLP-1s can go up to 1.7, sulfonylureas less than 1.5. So there is another aspect, which is a promising hormonal therapy. This is the pituitary receptor D2 agonist, dopamine agonist, and cabergoline is one of the compounds in this class. And now these pancreas has receptors for this dopamine D2, and so therefore there is, and there are various other hormones for which pancreas has receptors, and this may be something that future therapy must look into. So let's talk about metformin. Metformin in the beginning was thought to block gluconeogenesis, but that seems to be not true, more or less. So right now the consensus is it's mostly absorbed in gut and produces short chain fatty acids through Akkermansia mucinophila. Small amount of systemic absorption happens, and there is a nice study from Denmark using imaging on in which tissues it is accumulating and to what degree. But however, the real significance is mostly seems to be at the gut. Now, poor evidence for reducing insulin resistance. I will talk more about it if need be, and poor evidence in blocking gluconeogenesis. And B12 deficiency is one of the big issues in metformin, which actually makes the diabetic neuropathy worse. So, so really, even though it's very popular, this might have to be rethought. Now, sulfonylureas, DPP4 inhibitors, and GLP-1, I clubbed them into one compound because they all produce endogenous insulin. Glucose reaches the portal vein from the pancreas directly, and the glucose sensing in pancreas is not prevented by any of them, and continuous stimulation and secretion happens, and pulsatility is not restored, which we'll go into more details of this. Similarly, SGLT2 inhibitors and acarbose, they are also not doing any favor really, because the glucose still reaches portal vein, and then the glucose sensing happens, pancreas is overloaded, and continuous stimulation, secretion of insulin happens, pulsatility is not restored. So there are these iotropic effects that we talked about, and especially with exogenous insulin. So let's talk about main issue with exogenous insulin. It's causing hyperinsulinemia, as we will see in this talk. That is the one of the biggest issues in type 2 diabetes. It is also not helping, it is non-pulsatile, so it is overloading the system and making insulin resistance worse. It contributes to more ER stress and makes the vicious cycle worse. And then it also makes the receptors get saturated in muscle, liver, and adipose because of increased insulin resistance. So essentially the insulin binds to the receptor. Now there is more exogenous insulin. And so this is actually making the system worse. And we'll go into the mechanism of this a little bit more in detail. So the other thing I want to talk about is blame it on type 2, but basically blame it on hyperglycemia. So everyone for decades have thought endothelial dysfunction, and many of these aspects are because of the high sugar. But really hyperglycemia is a symptom, more or less like a fever, which is not necessarily the underlying cause. And so attacking hyperglycemia is in some sense not going to be as beneficial as attacking the root cause. And that's the focus of this talk. So there is a very nice video which I have in the references by Joshua Beckman. He is the head of the he's a vascular medicine, and he has studied endothelial dysfunction for decades and given a nice talk, which is on YouTube, which talks about why hyperglycemia may not be the direct cause, and even if there is some correlation, that may not be causative. So so the mission of my effort in the recent years is the following. So to generate an international consensus on to refocus from hyperglycemia to hyperinsulinemia, and then look at therapeutic methods, establish a well-funded institute to accomplish this, direct it, and then focus on early diagnostics, prevention, and cure. And the most important reason for this is before even we symptomatically find hyperglycemia, there is already damage being done in type 2. And that's what we want to address. So we also want to underscore iotropic issues and transient therapeutic improvements for the existing thing, which also will, of course, address the hyperglycemia, and then again, early diagnostics, prevention, and cure. So what we want to change is change the focus from hyperglycemia to hyperinsulinemia, and then bring back the pancreas to normal pulsed secretion, not over secrete and kill itself. So we want to improve the therapeutics to simulate the physiology as closely as possible, improve the pulsed endogenous insulin, early diagnostics again, and reduce hyperinsulinemia and hypersecretion, restore pulsed secretion, prevention via anti-inflammatory and antioxidants, which Professor Naresh will talk a lot more about this. And maybe, I mean, that is a bad word, that forbidden word, cure, but they're not afraid of addressing that. So let's look at the background for this that I kind of gave an overview, the etiology and progression. So let's look at endogenous secretion of insulin. Now, before that, I want to talk about exogenous insulin, which is the most widely used therapeutic compound, peptide, protein, hormone. It is the exogenous insulin that we get is non-native. It is not even, doesn't even have all the amino acids exactly as in human insulin most of the time. It is not delivered with C-peptide. It's not adaptive to insulin oscillations, which is actually the crux of the issue. We'll go into that. Both in my personal experience as well as in many others in the literature, there is weight gain. And especially this is all in the visceral fat, which is another dangerous thing. So now the features of regular endogenous insulin secretion is insulin is secreted almost every 15 minutes cycle, in a 15-minute cycle in a basal level. And of course, the pulsatility is maintained and the amplitude and amplitude might increase when there is feeding. But important thing is it's delivered directly into the hepatic portal vein as the blood into the portal vein comes in after feeding, and it senses glucose and then delivers appropriate amount of insulin into the liver. There is HPA axis and vagus nerve may be involved, but I will defer that now. These insulin oscillations, so this is just a diagram showing the anatomy, how the pancreatic islets directly feed into the through the portal vein. Here is another anatomical diagram. Now the insulin secretion, how it happens is there are the GLUT2 receptors on the pancreas, which is in GLUT2 in, there are only 3 main organs which can uptake glucose without insulin. So non-insulin dependent uptake is happening in liver, pancreas, and brain. And these are the vital organs for which glucose is always required. The GLUT2 receptor is bidirectional. So the glucose homeostasis is maintained between the systemic blood and inside the cytoplasm. And the glucose diffusion into the pancreas actually starts glucokinase, starts the glycolysis, changes the ATP-ADP ratio. That affects the potassium, which in turn changes the calcium intake, and that triggers release of the already made insulin in the vesicles. Now, one of the things that happens here is in the vesicles, the proinsulin is first expressed and made, and it is folded, and that needs to be chopped off so that C-peptide is released separately and insulin is released separately. So what's going on is here, the proinsulin is ready, but there are these processes that need to happen, which is chopping off the C-peptide and releasing the insulin. So any of the stress that makes these things rush through the process can cause problems. And that's what we are going to talk about more. So there is a lot of evidence that, the ER stress is what causes the loss of pulsatility as well as the beta cell dysfunction and maybe the death eventually. And also this is affecting the autocrine, paracrine, and endocrine functions of the beta cell. So this is very critical. This is So what is the reason why insulin is first going to the liver when the blood is coming? So as we know that first of all the food, first the blood from the intestines go to the portal vein. So that is when it knows it is feeding, and feeding is, this is very fascinating how the anatomy is all evolved to ensure that correct biochemistry is happening. So this is really fascinating. So what's happening is the portal vein delivers the blood, which is rich of glucose. Pancreas senses it appropriately. But the more important reason is that liver is producing sugar for those occasions where the glucose levels are lower for the proper functioning of the body, that it produces sugar through gluconeogenesis and glycogenolysis. And one of the main functions of the insulin is to block the gluconeogenesis in the liver. So it's basically saying, hey, I am coming, I'm going to address this excess glucose that is coming in through. So stop all the gluconeogenesis, and we will ensure that the amount of glucose that is in the blood is properly consumed. So then 70% of the insulin is absorbed by the liver. And out of that, only 30% is released back because there is insulin degrading enzyme in the liver. And so only a small portion of the insulin is released from the blood into the circulatory system. So essentially, the system is not utilizing large amount of insulin. That is a very pivotal point, and which will pave the way why hyperinsulinemia is a problem. So the other aspect is this whole pulsatility. So what does pulsatility mean for liver and the muscle? So when the glucose is sensed, and if we keep on releasing continuously insulin instead of a pulsed way, the receptors that bound the insulin don't have enough time to recycle. So there is a receptor saturation, they are constantly stimulated, and the insulin is bombarding the receptors. So therefore, there is not enough time to refocus or resynthesize appropriate things. And of course, this process is different in hepatic tissue, in muscle tissue, in adipose tissue, but the underlying bombardment continues, the underlying receptor downgrading happens, and this is exactly basically insulin resistance. Not only that, if the receptors in muscle, etc., are not recycled, and GLUT4 is not able to cycle through efficiently to take up all the glucose that is present, the cells are starved. And this, in effect, causes oxidative stress as well as inflammation, which is really the main issue. So we want to really address the receptor saturation, the recovery time to float the receptors back, address the insulin degrading enzyme to do its job correctly, and ensure that the liver can take up the 70% in every 15-minute cycle rather than continuously. So this, when this fails, this is when we have hyperinsulinemia. This is well documented, especially in the last 5 to 10 years. And there is increased evidence that in type 2 diabetics, there is hyperinsulinemia. And there is also more pro-insulin and more amylin than the ratio that is supposed to be, which means that the process of vesicular secretion is being rushed through. And essentially, pro-insulin doesn't have the correct time to fold the insulin, chop off the C-peptide, and release the insulin correctly. And the ratios have been measured, and they demonstrate alarming trends. So again, I kind of want to repeat what the thing is through this mechanism. So there is a glucose sensing in the pancreas that when it fails and when it is overloaded and rushed through, then that is what causes hyperinsulinemia, which causes endoplasmic reticulum stress, which makes islet malfunction, and then it continues to secrete, and then it causes receptor saturation in various tissues, which is essentially insulin resistance. That in turn, because because now the cells are depleted of glucose, causes more hyperinsulinemia, whether it be external or endogenous, and this is the vicious cycle that we need to address. So in the progression of the type 2 diabetes, there are various things that it can start, whether it starts from muscle or liver or various other places, or in beta cell itself. There is all these possibilities do exist. We would like to address this more carefully by through thorough experimentation and analysis. But in this talk, we are not going to go deeper into this. But I would like to say the following. For example, it is possible that by the age of 40, that the growth hormones and other things slow down. The aging process makes the muscle take less sugar, and the muscle mass decreases. That can cause certain amount of insulin resistance as a triggering point. But that may not be the triggering point, and maybe fatty liver is another problem. So there are different different points of nucleation of this process, but everything ultimately damages the beta cells pulsatility. And that is one of the issues that we kind of want to address. So now I want to really talk about a little bit insulin delivery as it is done in exogenously. And this is critical again to highlight this issue. So it is normally done through subcutaneously, through peripherally, and it's delivered peripherally. There is intranasal administration, and there is interesting through the hepatic portal vein directly. And I will talk about this. There is a lot of wonderful work done at Vanderbilt University by Professor Charrington's lab. And Dale Edgerton, what he did was he did surgery on 18 dogs just in 2019. This paper was published. I have the references. And he showed that if he delivers insulin directly into the portal vein, then the insulin resistance is much less, and the whole improvement of the physiology is very encouraging. Even more interesting is Dr. I forgot the last name, I'll get it. So he showed, he's a pediatric endocrinologist, and he has shown that administering exogenous insulin is causing type 2-like insulin resistance in type 1 people. So this is overwhelming evidence of insulin causing more damage. So we talked about this again. And so this is the recent work. Oh yeah, Justin Gregory. So recent work from Vanderbilt. So Dr. Charrington has been doing a lot of work. And incidentally, Joshua Beckman, he's also vascular medicine head at Vanderbilt. And so let's look at insulin secretagogues. So we have, before going this, so I want to say that exogenous insulin is not going to the portal vein directly. It's going through all over the body, and it's not doing what normal insulin would do, which is to stop gluconeogenesis by the liver immediately and then address the rest of the issues. The insulin is also not degraded easily through insulin degrading enzyme immediately, as it is happening in the normal physiological process. So the focus is then, can we look at insulin secretagogues as the golden apple, or so that we can address this issue and forget about exogenous insulin unless there is a critical clinical situation which needs to be addressed. So this is not to replace what is currently happening, but to slowly nudge the therapeutic process with more understanding of all these things. So the sulfonylureas, which have been in disfavor, but I think they are very important, and I'll come back to that. The DPP-4 inhibitors and GLP-1 agonists, they are basically on the same cascade. DPP-4 inhibits at higher level, and the GLP-1 agonists are the incretin class, which eventually affect the insulin secretion as well as reduction of the glucagon. Now, there is a lot of, I want to say fuss, but on our importance given to why these are cardioprotective. And this is obviously some amount of, there is obviously some amount of marketing aspect. It's not that cardio protection is not important. It is highly important, but is endothelial dysfunction and other things being caused by hyperglycemia, unless they have a independent reasons for cardiac issues, which can be addressed separately. So I feel that we should not necessarily intermingle cardiac protection from therapeutics for diabetes. As such, they have so many other side effects. So in the beginning, the sulfonylureas, which is very interesting, we're talking about cardio protection. The early sulfonylureas had sulfonylurea were interacting with the SUR receptors on the heart as well as the pancreas. But as the sulfonylureas came to third generation, fourth generation, they are a lot more specific to pancreas. So the early issues of cardiac issues coming because stemming from sulfonylurea is almost removed. Actually, what's his name? This person is originally from South Africa, but at Harvard, he thinks that we should bring back sulfonylureas, which are not in favor in USA by the FDA right now. Now the new drugs which are being patented and they have patent life, they are the DPP4 and GLP-1 agonists. Obviously, there is interest to push them into the market. We should not overlook the fact that they are under the patent, and therefore there is other interests. So these GLP-1 agonists, sulfonylureas, all of them can secrete endogenous insulin. At least it would block most of the gluconeogenesis appropriately, but they have not solved the problem of pulsatility. They are still overloading and overstimulating pancreas. Now, I was going to talk about, this is actually my talk in the Prague last year, was I was thinking of new sulfonylureas, which are maybe more targeted, which will stimulate less and maybe look at more mechanisms on non-ion channels or non-ion channels, or look at glycolysis, various things. But I think now our focus is a lot more on the pulsatility. So I was just having this repeat diagram so that we can look at different mechanisms where we could have addressed these issues. Oh yeah. So Professor Martin Abrahamson, he thinks we should bring this back. And some elderly patients may have some hypoglycemic issues, but that is really rare with things like gliclazide and new class of compounds which are used in Europe and in India, etc. So maybe one could do different things with titration and dose adjustment. The clinical studies on beta cell death, to what degree this is causing the hypersecretion definitely contributes to this. So that may be some aspect we need to look into. So what are the future priorities for this? So basically we want to understanding insulin secretion mechanisms, secretagogue mechanisms, toxic effects, local and systemic, new mechanisms, etc., and look at pulsatile secretion. So we are actually looking at these aspects, and hopefully we'll have more interesting results to present on how to do endogenous secretion while being pulsatile, and also look at how to decrease insulin secretion and see if we can prevent hypersecretion early, and early diagnostics. So this is essentially to repeat my mission, which is to change the focus from hyperglycemia, look at the atropic issues right now with the exogenous insulin, and even with other therapies, like for example, acarbose causes hepatitis, and SGLTs are causing amputation and some other problems. So there is many iatropic issues with each of these drugs. So we just want to change the focus, and I think we should focus more on hyperinsulinemia and maybe even prevent it early with early diagnostics. So just I want to emphasize the direction that I think we should all be moving, and this is so that's why I'm repeating this slide. So these are some of the references. If you need more, I would be glad to give them. And So I want to give some time for questions and discussion. Thank you.
Any questions? Any questions to Dr. Ravi Mubela? Okay. No, sir. No one is having the questions from yours for your talk. Thank you, thank you very much, sir, for speaking up in this meeting and providing a unique perspective on type 2 diabetes therapy. Thank you for sharing your tips with us. Looking forward to meet you again next time.
Sure. Thank you.
Okay. Next, we ask Dr. G. Naresh Kumar from MS University from India to join the event and start presentation.
Am I audible? Hello?
Yes, yes.
Okay. So in the outset, I'd like to thank the organizers for giving me the opportunity to talk on this, my topic, cellular inflammation in the etiology and treatment of type 2 diabetes. I'm going to concentrate on inflammation, type 2 diabetes, and novel probiotics. And my talk is going to be on these 5 areas I classified into. First aspect I'm going to address is the case for inflammation, that also the cellular inflammation. What we know is that type 2 diabetes is mainly caused by hyperinsulinemia, hyperglycemia, and insulin resistance. These 3 are involved. And the tissues which are going to get affected are pancreas, liver, adipose tissue, and skeletal muscle. So these interactions are going to cause the problem, that is clear. But what are the main challenges to be addressed in this? First question we want to aspect is that average age on the onset of type 2 diabetes is about 45 years. And second aspect what we have is that there is a problem of diagnosis. Right now, whatever we are able to diagnose the problem, by then people have shown that something like 50 to 80% of loss in the endogenous functions. That is quite serious. So our detection itself is quite late. And the hyperinsulinemia may be the primary weight cause gain that leads to obesity. So many people have believed so far that obesity is a precondition for the exhibiting of type 2 diabetes. That is why it takes very long time. But now it is coming that instead of weight gain, even hyperinsulinemia is going to be the precursor. So in this, the multiple factors are going to be responsible for this. The genetics, obviously, very important, but the genetics is not, that's going to be there from the beginning. So it cannot account for the late onset of diabetes. So we should focus on the reasons for the late onset of this disease. Second, hormonal misbalance. If you look at that hormonal misbalance, again, after a person reaches about adult stage, hormonal, whatever status is there, doesn't change much. So still it does not say why it should take 40 or 45 years for the onset. Then you can say aging. Aging is Um, Probably 40 to 45 is not really the aging problem, but maybe that can account for some amount. Then people also talked about gut microbial dysbiosis, but this is a very challenging problem because there is so many factors can influence the gut microbial dysbiosis. In lifestyle stresses, that's very important. We know that the circadian rhythms is very, very crucial. So the night work shift, irregular sleeping are very important aspects. And the other lifestyle problem is cigarette smoking. Many, especially the large number of Indian patients, seem to be getting the type 2 diabetes because of cigarette smoking. And I put the sedentary life as the last component, although it was considered as one of the very prominent, but that is also contributes certain extent, but may not be the major thing. Then the other factors which have been people looking at are the inflammation and dietary factors. In the dietary factors, there is a lot of correlation is there with respect to high amount of carbohydrates, specifically fructose and sucrose. Initially, there was a lot of emphasis on starch and component, but what research has shown is that fructose and sucrose are major problems which cause the insulin resistance. And then, of course, high fat. If you have too much of fat in your diet, that is going to make a difference. In addition to this, there's some sort of a deficiencies of magnesium and zinc that is also coming very important aspect. And then I have also put in the diet alcohol. Alcohol also contributes if you have over the limit, then it is known to cause a lot of oxidative damage, and that probably that also contributes to this. Then although all the things appear to be different, but all of them are interconnected. So for a long time, people have been considering the inflammation as the major factor which can explain for the late onset of diabetes. And what the first hypothesis was, adipose tissue, especially the visceral adipose tissue, that becomes a major amount. And that once the visceral adipose tissue is prone to causing some sort of a pro-inflammatory cytokines and also releases free fatty acids. These two are the things which trigger on inflammation and complications for the other tissues, implicating both pancreas as well as liver and skeletal system. So the inflammation was considered as one of the very important aspects. The pro-inflammatory cytokines are secreted predominantly by adipose tissue. But what we know is now that the hyperinsulinemia, oxidative stress, hyperlipidemia, all these things seem to be affecting at the energy level, which is going to be AMPK, which chronically activates, and then in the it is going to cause the ER stress and mitochondrial dysfunctions, because if you have an over amount of toxicity generated by hyperglycemic, hyperlipidemia, all these things are going to affect both mitochondrial as well as endoplasmic reticulum. That causes the toxicity. As Dr. Ravi talked about, when you have hyperinsulinemia, along with this, you have this amylin, and that amylin and proinsulin, they are going to also contribute to the inflammation. So the now the focus has changed from the adipose tissue inflammation to hyperinsulinemia. So what one of the current perspectives is, hyperinsulinemia is it's going to make adipose tissue inflammation. And you can see here in the inflammation the adipose tissue, the factors which are contributing for the inflammation predominantly are macrophages. These adipose tissue localized macrophages in the visceral tissue or even the normal tissue before that, where the hyperinsulinemia is going to trigger the inflammatory, pro-inflammatory cytokines. And this is, you can see the TLR4, this is coming from the microbial components from the intestine. That depends upon, again, the nature of the diet you take. It is going to modify. People have shown that if you take high carbohydrate and fat diet, the type of microflora is changing, is going to cause pro-inflammatory thing. So the PLRs and everything which are coming again is acting on the adipose tissue, is causing the same sort of, in a way, inflammation. And then these same cytokines are reaching to the other organs like liver. Liver is again a major organ which creates a lot of inflammation. So the macrophages which are present in this are going to trigger on this. So the second level of hypothesis was hyperinsulinemia is triggering the macrophage functions in the adipose tissue as well as in the liver. So, and this hyperinsulinemia is not only restricted to type 2 diabetes, it is implicated nowadays with the obesity, cancer, chronic inflammation, hypertension, atherosclerosis, and all the things. So they seem to be very interesting relation that pancreatic beta cells somehow dysfunction seem to be responsible for many other diseases. Why it is there? That's a very challenge to understand thing. So now, when we look at the inflammation, everyone agrees now that probably inflammation progresses along with the life. Around 40 years or something, probably it could increase, and that could account for the cause of onset of the diabetes. Now, I would like to address on the changing concept on the inflammation itself. So the focus now changes from the classical inflammation to cellular inflammation. So in the classical inflammation, it is associated with some sort of a tissue damage. You can see all these 5 different phenotypes which are associated with the inflammation. And then the inflamed regions, you have the neutrophils and monocytes migrating, and you have the neutrophils activating macrophages, and the main inflammatory response in this damaged portion of the tissue is the macrophages and neutrophils, and their action is necessary for the wound healing and recovery. So, and in this, there is again 2 different types of inflammation was known. One is what we called about acute inflammation, which is caused by some sort of a tissue damage or some sort of a infection. But there is also something is known as chronic inflammation. This could be because the body is constantly being exposed to some sort of an toxic agents which are triggering on inflammation, or some sort of infections which stay for a very long time. So this is a chronic one, but in all these cases, the main inflammatory cells are the neutrophils and macrophages. And some of the diseases what are related with this are classically rheumatoid arthritis and autoimmune diseases. In addition to this, what has emerged as the cellular, what is different inflammation, what we call cellular inflammation. This is occurring at the almost all cells, and it is supposed to be chronic, and it is implicated in disrupting the hormonal signaling. And the mechanism and components are completely new in this. The central aspect is what the transcription factor, what is called a nuclear factor kappa B. So, and here the in cellular inflammation is controlled by two different signals. One is TLRs and some sort of cellular communication where the paracrine or environmental factors which trigger on the pathway, ultimately bringing about NF-kappa B. NF-kappa B is a thing which produces what is called the IL-1 beta and IL-18. These are supposed to be present in pro form, so they really don't cause any sort of inflammatory. They are inflammatory cytokines, but they are not really in active form. In addition to this, what happens is the NF-kappa B produces certain proteins which are responsible for forming the next step. The cell is getting prepared to counter the phase attack from some sort of a pathogens or metabolic damage or whatever things are there. So that is what is seen as what is the inflammasome. The NLRP3 is also expressed by this NF-kappa B. So the second, if the damage, whatever metabolic problem or whatever the agents which are trigger on this damage are controlled, then the nothing will happen. But if it continues for long, there is a this is associated with what's called second signals. These are what is called the damage associated molecular patterns. That is, whether it's a mitochondria or a nucleus or there's some sort of a metabolic problem, the membrane permeability of mitochondria, or some are the mitochondrial DNA coming out, mRNA coming out, ATP is being present in more amount in cytoplasm. There's many factors which are called the damage associated signals or danger signals. So those things will activate this into the inflammasome. So first step is, first signal is responsible for making the inflammasome proteins to be formed, and the pro-inflammatory cytokines are present in a inactive form. And once the problem continues, then the inflammasome is formed. This inflammasome has a capacity to convert this pro-form into activated form. So these activated cytokines, then the inflammatory cytokines are secreted. So this is entire phenomena is called the cellular inflammation. So, and what is the significance of this? You can see that the important aspect of this inflammation, cellular inflammation, is to cellular repair. The first level of all these two things activates what is a process. There are macromolecular components inside the cell, whether it's the protein complexes or damaged mitochondria. These ones are the things which need to be eliminated. So this inflammasome, which makes the cellular process what is called the autophagy, and mitochondrial removal is called the mitophagy. And these are the things which eliminate the damaged components of the cellular. So that's how the cell becomes comes into functional form, by removing the dysfunctional and damaged cellular component. So in cellular inflammasome is some sort of a repair mechanism which is going on. But if as the two kinds of systems are known, in the same person at the later stages of age, these cells, the inflammation becomes a little bit more, and that is also called inflammaging. So the damage which is continuing need not be only in terms of old age. It can be the persistence of the inflammation triggering damage causing problem. If it continues, this causes inflammation. So If this continues further, now cell is not able to repair itself, then it undergoes a death. There's a programmed cell death is there. So it depends upon the type of organ which is the problems are there. There are different ways the cell dies. This is called apoptosis or a pyroptosis or ferroptosis if it is the plasma membrane and lipids are damaged, and necrotopsis if the lysosome is involved in that. So the cell dies. But in a tissue, with these dead cells cannot be there. First level of inflammation is to repair the cell. Second level is saying that cell cannot go further. Now it has to die. Then if the cells debris is accumulated, then going to be serious problem for tissues. So those debris actually trigger on macrophage activation. Normally, the cells are dying all the time, so they are being replaced and new cells are generated. That's what happens in the normal tissue homeostasis. So the the cell which is dying, apoptosis or all these things, it expresses certain signals on the cell surface that those are called the eat me signals. And they also send sort of a signals for the macrophages which are present in the tissues. The what is known is all tissues have macrophages. These are not inflammatory macrophages. These are the cells' job is to remove the dead cells. So these signals, when these cells are dying, because of the cytokines which are secreted, IL-1 and IL-18, the tissue localized macrophages come near the thing that's called the chemotaxis. They come near that and then they get activated by the components, and they produce what is called the signal to find me signal. So the macrophages normally they undergo not activate this process, what is called a phagocytosis, that is not activated. But when you have the cells which are dead cells on the cell surface, you have this phosphatidylserine. This, when interacts with the tissue localized macrophage, then it gets activated and removes that. So this process is called the efferocytosis. So the cell, dead cell is removed. So now what happens is these are called by the tissue specific M2 macrophages. So that the dead cells are gone. Now each and every tissue has stem cells. These stem cells now regenerate and produce the tissue. So tissue homeostasis goes on. So everything is functionally normal. So this was the classical problem what was there, that earlier macrophages, whatever were there, first identified cells were what we call the macrophages with inflammatory functions. They used to produce the inflammatory cytokines. There's the TNF alpha, IL-1 beta in exceedingly high amount, and they are get activated by also activate the signals are coming from the either pathogens or the second component what we have in the blood with the complement system. This complement system also, when they get activated, activates the macrophages. These are the classical macrophages which have been initially identified. They were also known about the tissue localized macrophages, but for the recent last 10 years, it was become very clear the origin of these two cells and function of these two cells are entirely different. The tissue localized macrophages is called the M2 macrophages. These are the resolving macrophages. They have different identifying markers. You can see that very important function of this is to eliminate the dead cells and dead molecules, and this is called the efferocytosis. On the other hand, the M1 macrophages are do this function. These are generally from the monocytes which enter into the tissues in response to either the classically the tissue damage or to the pathogen clearance. So the uh, you have inflammation, cellular inflammation. It can be triggered on by either endoplasmic reticulum stress, mitochondrial dysfunction, DNA damage, or lipid damage. Whatever the factors are there, they can initiate this. And what happens is this is triggering on reactive oxygen species, and they are producing the cytokine IL-1 and IL-18 in a pro form, and then it is activating micro and macro autophagy and the repair system. And this is generally happens, this is what I called it as stage 1 level of cellular inflammation, which is maybe takes in hours to days time scale. In the second level of thing is that continued DNA damage, membrane damage. These are activating second signal. This is what you call the inflammasome. The inflammasome, once it is activated, then the pro-inflammatory cytokines IL-1, IL-18 are produced. Then you also produce eat me signals. Then cell death is going to happen. And this is what the regeneration and cellular homeostasis. This happens in the probably in the time scales of weeks to months. So these are the normal things. But beyond this, if there is a problem with the all this, whatever we talked about, the endoplasmic reticulum damage and mitochondrial dysfunction, all these things are continuing, and you are creating more amount of ROAs continuously over the long period, then you have the problem of the signals coming, where the two kinds of situation happens. One, the interleukins which are secreted, IL-1 beta and IL-18, now TNF alpha, they're higher and more. So that makes the monocytes to migrate into the tissue. And these monocytes which are migrated, now they become M1 macrophages. These M1 macrophages that we have already seen, they are produce very high levels of TNF alpha, IL-1 beta and IL-6. So there is a clear-cut difference between the levels of what is produced by normal cells and inflammatory macrophages. So there is a sequence of events which happens now. The M1 macrophages also convert localized M2 cells also become M1 macrophages. In addition to this, these macrophages also activate, there are certain cells which are present in the tissues. These are called the innate lymphoid cells. These have been identified recently, some 10 to 15 years back. These are like macrophages, they are resident in the tissues, but they don't get activated. But once the inflammation becomes very high, these things get activated. And what do? See, more and more inflammatory cytokines are produced, then it will produce what they make the migration of CD8 cells. CD8 cells are T cells. They're very, very potent and specific cells. So now the inflammation becomes so high in the tissue, then these are going to cause tissue damage and dysfunction. So although I have put it in one column, this is can take pretty long time. It can start from the process from months to years. So this is once this process comes in, then the tissue is going to be a problem. So this is what is cellular inflammation, connection, making macrophages getting into the thing. So most of the time, there is some hyperinsulinemia itself probably is created in response to pancreatic B cells undergoing inflammation. So I will try to give you some of the evidences which have come recently on trying to show that. Uh, normally, in pancreatic B cells, the protein insulin is produced in extremely high quantity, something like 8,000 to protein insulin molecules are produced per second. This is one of the highest probably in the cells made. So, and on the top of that, we are talking about hyperinsulinemia. That means even the synthesis increase continuously for a very long time. So, if it protein expression in the insulin happens in the endoplasmic reticulum, we know that the various stages are there. The insulin has to be the pro-insulin form. You need to produce disulfide linkages and cleavate. All this process takes place in the endoplasmic reticulum. If the protein expression is very high, that process become a problem. And so the proteins become in a unfolded or a non-native form. These are called the unfolded proteins. And if they are present in endoplasmic reticulum, this is cell sends a signal, ultimately giving rise to activation of the inflammation. You can see that this is directly activating inflammasome, and the inflammasome activation is going to the second signal. So the UPR stress is going to be very important in converting it to the. But in normal cases, even the inflammasome is going to be only involved in the mitophagy and apoptosis. There is no problem. But sometimes something is happening in the pancreas. This M1 cells are crossing, and M2 cells are crossing and making M1 macrophages to come in. Why and when it happens is a crucial step for the inflammation to happen. But what people have shown is like this. The glucose high levels, normally insulin release is going to control the insulin secretion, so there is no problem, is going to be compromised. But if the glucose levels are increased, then NLRP3 going to get activated. If it remains the glucose in little bit longer than normal, then the inflammasome gets activated. Inflammasome gives the IL-1 beta, and this is going to cause the apoptotic B cell. So this is second stage is going to reach in case of this is what they have shown. And then you can also see already in this case, they are showing the macrophage producing IL-1 beta. So that means that the pancreas M2 macrophages already have become M1 or monocytes which have come inside the thing. So this still, it is not clear in the pancreas how these M1 macrophages have come. So once the M1 macrophages have come, so this process is going to get triggered on. So the same scenario as it goes on, apoptotic cell, and the more amount of IL-1 beta production by macrophages going to B cell, and B cell is going to act on more on whatever is released from here. The IL-1 beta can do two ways. One, it is in the paracrine response near the cells within the islets and pancreas. And it also goes inside the blood and act on the insulin sensitive tissues. So the hyperinsulinemia as well as the inflammatory cytokines which are produced in the pancreas can go and trigger on the act on other cells and can initiate the same process in other cells. So this is what has been shown. You can see here what has been shown here is that pancreatic beta cells having inflammatory cytokine, and you have all cells are involved in this. In the case of type 2, we have already, you can see that macrophages, T cells, NK cells, all of them are there. So that means the pancreas has become highly inflammatory. Whatever conditions I have shown you, already seem to be happening inside the pancreas when the type 2 diabetes, or maybe even before. So we need to now identify exactly pre-diabetic case and diabetic case, how this process is going on. Okay. Overall, what is known, if you have this overfeeding of the so what has been presumed, the hypothesis is you have amount of food taken is very high. That is making the diabetic, the pre-diabetic cell causing these inflammatory cytokines, making insulin resistance. This, because of this high amount of things, causing oxidative stress. Oxidative stress, initial levels, there is some sort of a compensation, but that is increases further, it is going to cause the glucose stimulated insulin secretion is going to get affected. Then it is going to get into the more and more model. So this is the hypothesis which is proposed in the meaning, the lipotoxicity and glucotoxicity, all these things are triggering on associated with ROS, and ROS in turn connected with the inflammation. So here you can see that the cellular inflammation, the mitochondria, the endoplasmic reticulum, in all this case, you have the oxidative radicals, H2O2, reactive oxygen species, all are getting generated because of this multiple reasons. And so this is, in turn, you can show that this is activating to inflammation. So there is a relation between the metabolic function, where when you have high amount of glucose, the mitochondria is not able to oxidize, so much of glucose is getting. If it is not able to oxidize, then the mitochondria generates reactive oxygen species. The reactive oxygen species is going to talk about the inflammation. So the endoplasmic reticulum, it is because of unfolded protein response. In mitochondria, it is because of the mitochondria is not able to oxidize more amount of acetyl-CoA. It can also come from more amount of fat. Fat, if you have more amount of acetyl-CoA, that also, if the mitochondria is not able to tackle that, it is going to create more amount of ROS. So multiple ways ROS get generated. ROS is going to create the inflammation. So now there is an interconnection of the ROS, and this is some sort of a molecular mechanism which is known, the cell signaling component, which are associated with the mitochondrial damage functioning, and then the inflammasome activation, first and second level, both will happen because the mitochondrial thing is going to cause the inflammasome. So directly you are getting into the second phase. So now if you have these cellular inflammation and ROS are interlinked, can we have some sort of a role for antioxidant and inflammatory compound for tackling the type 2 diabetes? So this is again showing the different cellular component. This can happen from mitochondria, endoplasmic thing, everywhere. So the reactive oxygen species are there. So why I'm showing you this is very important. In the cellular component, we have two types of antioxidants. One is enzymatic mechanism, other one is non-enzymatic. Non-enzymatic is your vitamins. Ascorbate is vitamin C and vitamin E. Vitamin C is mainly for cytosolic oxygen radicals which are present in water-soluble form, whereas vitamin E, it takes care of the membrane lipid peroxidation. So these are the two regions. It can happen in any part of the cell. The interesting component is now people have shown the endoplasmic reticulum and mitochondria are in contact with each other. That is probably important in calcium exchange from these two organs, and these regions may also be involved in the oxygen radicals going from one to another. So whether it is a UPR stress or mitochondrial damage, though in the cell, they're going to be coupled together. So there is a new type of evidence which is coming, and the protein folding UPR tissue generating reactive oxygen species is a mitochondria. So the system is getting problematic. Wherever the problem is there, it is going to affect. That means if endoplasmic reticulum, because of UPR stress it is there, it can affect mitochondria. Mitochondrial lipid metabolism, biosynthesis, or fatty oxidation can be covered. So it depends on the tissue, whether it is adipose tissue or muscle or beta cell. The functions of both ER and mitochondria getting interlinked, and the endoplasmic reticulum is important in calcium release and signal transduction. If that does not happen, it will again cause your insulin resistance. So the ultimately the reactive oxygen species and inflammation seem to be important in the progression of all tissues. This same little bit, so how this thing connected the junctions between endoplasmic reticulum mitochondria is involved in the inflammasome formation. So overall, what we are seeing is oxidative damage in the mitochondria or endoplasmic reticulum is going to activate the inflammasome. Inflammasomes are making the NF-kappa B, NF-kappa B, and the whatever damage components are there from mitochondria, these are converting and making into cellular process, cell death, and triggering on. So if these things are there, then can we have the antioxidant which can help? So if you look at the antioxidant, ascorbate, the problem of antioxidants is they also are susceptible to damage by oxygen. Oxygen radicals are very, very chemically reactive. Almost every molecule get damaged by this. So what the number of times a molecule can convert reactive oxygen species into water, that is called the redox cycles. Ascorbate can undergo 4 cycles. That means one molecule of ascorbate can convert 4 hydrogen peroxides into water. After that, it gets damaged. So this is tells you about the antioxidant potential of various molecules. So if you look at various quercetin, which is the highest one, all this is at the 800 redox cycles. There is another molecule, very interesting molecule. This is produced by bacterial systems. And this is called a pyroquinoline quinone. You can see the structure. It is extremely stable. And so it is, redox cycles are 20,000. It means it is 5,000 times more potent than ascorbate. And you can see that even quercetin, it is much more potential than that. And what is known is that this is a sort of an essential nutrient for us. Some time back, they were trying to consider this as a vitamin. And interesting thing is this is involved in mitochondrial biogenesis. So it's a powerful antioxidant. It is a mitochondrial biogenesis. And the large amount of studies have shown that this is involved in cellular signaling pathways, many pathways. You can see that NF-kappa B controlling and mitochondrial genesis, and there is something called PGC1 alpha. This is involved in the antioxidant enzyme production. So the PQQ is antioxidant and very good potential. So people have been using this for as an anti-inflammatory compound. Many studies have been shown in the anti-inflammaging. Recent publication has shown that it can prevent this, and in obesity and hepatic lipotoxicity, inflammation, and NF-kappa B and JNK activation, mitochondrial inflammation. So many inflammation, this has been very, very effective. And this is the people have shown how this mechanism also operates in the thing. TN-alpha mediated transcript activation is downregulated by PQQ. PQQ inhibits this, so that is how it protects the cells undergoing more inflammatory component. Then we have another vitamin, the tocopherol. This, but the another similar compound, which is called trienol. Trienol, you can see the structure. It is smaller than tocopherol. Tocopherol and these two are hydrophobic in nature. So what will happen is these molecules go inside the lipid membranes, and the whatever damage is done, these are the redox anti-redox potential they have. So because of the small size, this can penetrate into the membranes much more efficiently than tocopherol. So people have recently, tocotrienol is emerging as a very, very good antioxidant, and people have been using it for cancer, obesity, and many other cases. This is the studies shown that it goes in liver, muscle, pancreas, in all other cases by different by molecular mechanisms, and then it inhibits the adipogenesis, the induces apoptosis, and anti-inflammation. So the tocotrienol is again seem to be very effective in addition to antioxidant potential, and recently they have again shown that anti-senescence, almost a similar type of thing, anti-inflammasome, obesity, kidney disease, and NF-kappa B inflammation. So the mechanism is also have shown exactly how it acts. Molecular mechanism, will not go into the details. These are the how it prevents the NF-kappa activation and activates the response. So the another well-known compound all of us are familiar is curcumin. It's a part of component of the haldi, but these people have used, because of the lipid solubility, nanocurcumin been used, and this has antioxidant as well as the NF-kappa B controlling activity. So you can see that there's been very well established. Large number of reports are there. A few thousands of papers have come on curcumin trying to show its anti-inflammatory and antioxidant potential. So the last part of my talk is on probiotics. Probiotics are present in the are the organisms, bacterial systems used, which we take in the food orally, and they're going to confer the beneficial health effect. They have been function by balancing the intestinal microflora, the GA tract permeability is controlled. They also involved in the reducing serum cholesterol. Immune system is also controlled. Elimination of toxins, and they also can prevent cancers. So there are the multiple ways these probiotics work, and there are many types of bacterial systems are known, and not only bacteria, some of the fungi and yeast are known as a probiotic component. So these probiotics are also shown, because they stay in the GA tract for long period, they help in the suppression of many diseases. People are shown control of inflammatory bowel disease, improved lactose intolerance, and lowering cholesterol. Many ways the probiotics are very useful. And another interesting aspect is that the microbiota, beneficial microbiota, is they produce what is called the short chain fatty acids. These short chain fatty acids are go into liver, intestine, they act on that, it produce incretins, and they go into the liver and cause a lot of beneficial effect. very well established that short chain fatty acid receptors are present in adipocyte, pancreatic beta cells. They are helpful in insulin secretion. So the probiotics can also work in this fashion. So for last 10 years, we have worked on the E. coli probiotics. What we have done is we have done extensive genetic manipulations. This we have taken a well-established E. coli probiotic, what called Nisel 1917, and we isolated our own strain, what is called CFR16. So what we did many things. First thing is what it called increase the colonization in the GI tract by using some sort of hemoglobin, and then we could tag it with a protein, GFP tagging, so that we know exactly what strain is present in there, because the intestine contains something like 10 to the power of 14 bacterial systems and something like 1500 different bacteria. So we need to know exactly what happens. So we have done the PQQ, we overexpressed it in this, and we monitored oxidative stress and neurotransmitter modulation. And we have secreted some enzymes in this, they called inulosucrase. This converts sucrose into inulin. So it helps the sucrose mediated metabolic disorders are taken care by this. And then when we did the PQQ, in the it also overcome the oxidative and damage and hyperlipidemia caused by ethanol. There's a chronic ethanol consumption is taken care. And then we also shown it helps in the mitochondrial function, that helps the rats to survive much longer. So anti-aging capacity. And then we did some another set of modifications which converts fructose into mannitol. Mannitol is again what is called a prebiotic. So this helped in the converting the fructose into mannitol, which decreases fructose, again fructose mediated metabolic disorders. Then we have also done other modifications which helps the cadmium and mercury damage by using this. So overall, the already I had shown you in the type 2 diabetes, some of the dietary component, sucrose, ethanol, and fructose, this can be taken care by this. So so in the what this I'm suggesting that the combination of the antioxidant and anti-inflammatory things, these are the PQQ with water soluble and component, and these ones can really help in probably. This is a supplementary thing, not a substitute for the existing strategies. So, uh, so there are some issues we can, as I already told you, that M1, M2 transition is a crucial thing in understanding. So thank you.
Any questions to Dr. Naresh Kumar? Any questions? Okay, thank you very much, sir, for participating in this event. On behalf of Organizing Committee of Diabetes Congress 2020, I want to thank you for insight presentation. Looking forward to meet you again next time.
Thank you. Thank you.
Now we asked Dr. Martinez Venegas Martinez from Institute Politécnico Nacional of Mexico to join the event and start presentation. Hello. Hello.
Yes. Yes.
Yes,
Just
yes.
5 minutes. Thank you.
Yes, okay, madam. Take your own time, sister. After Dr. Martinez, Dr. Mary Limbe will be going to the presentation. So meanwhile, we ask to everybody to get ready with your presentation. PPT.
Hello, everyone.
Yeah,
Can you hear
you
me?
can start after. Yes, madam. Just meanwhile, Dr. Martinez will be going to start. Just after Dr. Martinez, you can start your presentation.
Oh, I'm so sorry. I thought you said.
Yeah, okay.
Sorry. Let me get off there.
Because yes. Okay, no problem.
I'm so sorry.
Just be online.
Hello. Do you listen me? Maritza from Mexico.
Just adjust your settings, madam.
Sí. No me veo. Hello, do you see the screen? Es que no sé si ven la pantalla. Okay, yes. Let's going to start. I'm Maritza Martinez from Mexico, and I'm going to present diabetes. Bueno, yo soy de la Escuela Superior de Medicina del Instituto Politécnico Nacional y nosotros trabajamos en enfermedades cardiovasculares.
Excuse me, madam. Just we are unable to see your PPT. Yes, yes. Now it's going to.
Yeah, do you see screen?
Yes, just you can enlarge it. Ah, yes, it's fine.
It is fine? Yeah,
Yes,
do you
yes,
see?
yes, yes, yes,
It is fine.
yes, yes,
Can I start?
yes.
Okay. I'm from Mexico, and I will talk about diabetes in our country. And mi experience in Escuela Superior de Medicina del Instituto Politécnico Nacional. Here in Mexico, this school is only for medicine, and I will talk about it. Mi plática es Intensive Treatment Advantage in Diabetic Patients under 5 years of diagnosis. En las pláticas anteriores, nosotros hemos escuchado cuál es la fisiopatología y la importancia de la diabetes alrededor del mundo. Sabemos que esta enfermedad se ha vuelto de gran importancia en todos los países. Y bueno, con esto de la pandemia, pues ha dejado ver en situación que nuestros pacientes son vulnerables y que se mantienen su calidad de vida y sobre todo los estándares en su hemoglobina glicosilada. Y pues para hacer un recordatorio vemos que alrededor del mundo existen 463 millones de adultos que viven con diabetes. Esto se incrementará con una muerte por cada 8 segundos. Eso es muy importante y sobre todo los factores de riesgo que tienen aquellos que pueden ser modificables y los que no pueden ser modificables. Como hemos escuchado en diferentes pláticas, pues la obesidad, el sedentarismo, el sexo y sobre todo nuestra nacionalidad juega un papel muy importante. ¿Qué va a pasar? Pues esta cifra se va a ir aumentando para el 2030 y lo más grave es que para el 2045 existirán 700 millones de personas. Es una cifra muy alarmante. Y bueno, como hemos visto alrededor del mundo, pues esta prevalencia es en edades de 20 a 79 años. Esta población es muy joven. ¿Y qué llama la atención? Pues bueno, en nuestra región de América del Norte, pues se encuentra México. Y en el 2019 veíamos que existía un 11.1%. Claro, para este 2020 y con lo de la pandemia, esta cifra ya se disparó, que es también alarmante. Ahora, la proporción de personas que mueren por esta enfermedad por arriba de los 60 años, pues como vemos en México es de un 40 a un 60%, o sea, nuestra población todavía se encuentra entre adultos mayores y jóvenes. Entonces, es una etapa muy productiva, entonces hay que poner especial atención. De manera específica en México, ¿cómo ha sido este aumento o crecimiento de la enfermedad? En el 2012 teníamos en cuenta que el 9.2% eran hombres. Para el 2018, esta cifra se aumentó y de 9.7 a 11.4. Sobre todo en el género. ¿Qué está pasando? La mujer en nuestra sociedad tendríamos que poner mucha atención. Los hombres en el 2012 contaban con y para el 2018 se aumentó a 9.1. ¿Cómo estamos viendo la población de 20 años y más? Es una población muy productiva y eso impacta en esta sociedad, sobre todo en estos tiempos de crisis. En México existe un estudio en el que reportan que tanto hispanos como América Latina se ve afectados. ¿Por qué? Pues es la genética, es la ingesta de comida y la actividad. ¿Qué tenemos? Nos dicen que los genes juegan un papel importante en el desarrollo de la enfermedad. La comida, como ustedes sabrán en México, la mayoría de las personas comen grasas y sobre todo esta parte de nuestra raíz que es el maíz. Las celebraciones en familia son un papel muy importante y todos nos reunimos a la mesa para comentar sobre nuestro día y celebraciones y comer demasiado. Pues la verdad es que no somos una población que se caracterice por ser muy atlética. Sin embargo, se ha visto que somos la población que tiene menos actividad física. Y bueno, para entrar un poco en el tema y ver después de que hemos escuchado unas prácticas muy interesantes donde la inflamación juega un papel muy importante, se sabe que la obesidad es una condición de inflamación crónica y constante y que los pacientes que tienen diabetes, pues la mayoría tiene sobrepeso y obesidad. Y bueno, los estándares de este año pues no se quedan atrás y partimos. Y en el caso para mi tema es saber que la metformina sigue siendo el estándar. Si bien es la primera línea, entiendo que todos tenemos que individualizar nuestros tratamientos hacia nuestros pacientes e ir marcando. Yo les voy a presentar que en México existen programas y sobre todo guías de actividad física. Estas guías y estos programas, ¿qué es lo que tratamos de evitar? No queremos que existan estas personas sedentarias que se sientan a ver la televisión más de 3 horas, que esta ingesta debe de cambiar por frutas, verduras y sobre todo mantener este balance. ¿Qué es lo que es importante para entrar en este tema? Hay que recordar la historia natural de la enfermedad y sabemos que una vez que nosotros hacemos el diagnóstico, por lo menos han pasado 5 años desde que la persona empezó a sentir cambios y sobre todo estos cambios que van a ir marcando la aparición de complicaciones microvasculares y macrovasculares. Sin olvidar que esta etapa de la prediabetes la estamos olvidando, las intervenciones las estamos haciendo de manera muy tardía. ¿Qué pasa? Cuando yo hago el diagnóstico, nuestra célula beta se encuentra ya por lo menos en un 50% de su población. ¿Qué es lo que va a pasar? Que efectivamente, como hemos visto y todos sabemos, nuestra insulina está en decremento. No hay un buen aprovechamiento, no hay una buena cantidad. Se está generando una resistencia a la insulina, esta secreción se ve mermada y sobre todo la variabilidad glucémica que existe a nivel post y preprandial. ¿Qué va a pasar? Que una vez que nosotros hacemos el diagnóstico, todo esto se va a seguir potencializado, el efecto incretina seguirá decayendo y pues bueno, nuestros pacientes estarán en este dilema de estar bien controlados o no controlados, con cifras que nosotros queremos mantener por abajo de 6.5 ideales. Hay que recordar que todo esto tiene que ver en relación de nuestra edad, del género y de la población y sobre todo los factores de riesgo y de familia que llevamos. Bueno, como ustedes saben, existen muchos estudios, sobre todo el Advance, el UKPDS, el ACORD, que en su momento hicieron un seguimiento de más de 10 años con una población bastante extensa, con masculinos y femeninos, y ¿qué vieron? Llevar un tratamiento estándar donde solo era la dieta, pues sí había un cambio, pero no era el cambio ideal que manteníamos, puesto que las complicaciones seguían apareciendo. Agregaron un grupo que le llamaron tratamiento intensivo. ¿Y qué pasaba? Eran cambios al estilo de vida, un tratamiento farmacológico integral, atención psicológica, y esto se vio en un mejor control de la enfermedad. La aparición de complicaciones se retrasó y sobre todo la muerte. Y como lo vemos aquí, esta gráfica nos enseña que aquellos pacientes que tenían al momento del diagnóstico una hemoglobina por arriba de 8, con el tiempo, al primer mes, veían un cambio. 6 meses, 12 meses, hasta incluso a los 2 años veíamos que se mantenían estas cifras por abajo con un tratamiento intensivo. Esto nos da la pauta para seguir recordando que nosotros, una vez que hacemos el diagnóstico, no solo podemos hacer cambios al estilo de vida y un fármaco. Necesitamos ver más de 2 fármacos, acordarnos de los triglicéridos, del colesterol y sobre todo recordarles que es cambios al estilo de vida. De manera que una vez que hacemos el diagnóstico, si solo mantenemos el cambio al estilo de vida y un fármaco, vemos que este control que pudimos haber encontrado se va mermando y entonces nuestro paciente empieza a tener bajo control y sus cifras de hemoglobina vuelven a subir, que es lo que hay que recordar, que nuestro cuerpo tiene una memoria metabólica y como bien lo dijo anteriormente el doctor, la inflamación juega un papel importante. ¿Por qué? Porque seguimos teniendo esta cantidad de adipocitos en concentración, interleucina 6, TNF-alfa, toda esta vía de señalización que se nos ve involucrada. Como lo vemos aquí al año, a los 4 años, nosotros ya vemos que este paciente, de haber estado en control, empieza nuevamente con cifras elevadas. Y bueno, yo les voy a presentar lo que nosotros hacemos en el estudio y vemos que nuestros pacientes eran personas de 5 años de diagnóstico. ¿Por qué? Porque vuelvo a recordar, cuando nosotros hacemos el diagnóstico, se sabe que han pasado de 3 a 5 años. Por lo que si nosotros sumamos, son 10 años en el que este paciente ya se encontró bajo los cambios de la inflamación, del estrés oxidativo y sobre todo que ha mantenido esta parte de la obesidad. Nosotros lo dividimos en 2 grupos y vemos un grupo que recibía metformina, vildagliptina, este inhibidor de PPP4 que en nuestras estándares el ADA lo ha ido mejorando en su momento. Ayer hablaban justamente de este grupo farmacológico y decía que en los pacientes que tienen la enfermedad de diabetes y que aparte tuvieron la desgracia de ponerse con COVID-19, les infería un factor de protección. Entonces, pues, esto habla de un buen control, ¿no? En este grupo de estudio. Ahora, tenemos un grupo que recibe insulina. De manera específica, este grupo de insulina que yo les voy a mostrar es un grupo de insulina preméscula. A este grupo nosotros le hicimos un tratamiento y un seguimiento de índice de masa corporal, hemoglobina y triglicéridos. ¿Y qué encontramos? Si bien nuestros pacientes tenían menos de 5 años, el índice de masa corporal al momento del diagnóstico se encontraba más o menos en 32. Estos pacientes tenían una obesidad y una vez que les iniciamos el tratamiento con metformina, o sea, más cambio de estilo de vida, más un inhibidor de PPP4, vimos que este índice de masa corporal disminución para llegar a un 29. Entonces ya no estaban en un grado de obesidad 1, sino que se regresaban a un sobrepeso. De manera que el grupo que recibía una insulina premezclada tenía un índice corporal de 29, sin embargo, con el tiempo, o que se les agregaba insulina, veíamos que este índice subía. Como nosotros sabemos, se sabe que sí la metformina tiene un impacto en el grado de obesidad y que sí tiene un impacto en la disminución del peso corporal. Sin embargo, la insulina promueve este aumento en el peso corporal. En cuanto a la hemoglobina glucosilada, ¿qué fue lo que encontramos en nuestro estudio? Pues encontramos que el grupo que recibía metformina vildagliptina se encontraba en cifras de 7.6 y cuando nosotros le agregamos el tratamiento, esta cifra bajó hasta 7.2. Si bien no son cifras de control óptimas, vemos que esta tendencia a la disminución es bastante importante y pues más al favor de la diapositiva anterior en el que vimos que el peso corporal se veía reducido. ¿Qué es lo que pasaba con nuestro grupo que recibía insulina? Pues nuestro grupo partía de una cifra de 8.5 a 8.7. Nuevamente veíamos que la insulina bien no hacía una diferencia significativa en la hemoglobina glicosilada, pudiera ser por el tiempo en el que se le hicimos este corte. Ok. De manera específica, ¿qué encontramos en los triglicéridos? Nosotros encontramos que estas cifras estaban elevadas en nuestros pacientes de metformina que recibieron el tratamiento, aumentó a 228, lo que nos habla de que en este momento o en el tiempo de nuestro corte, metformina no había hecho un cambio significativo en los triglicéridos. Para el grupo de insulina premezcla, los triglicéridos si bien estaban ya por arriba, casi en los 300, no hubo una diferencia significativa cuando se empezó el tratamiento. ¿Cómo encontramos los HDL? Como hemos visto en las pláticas anteriores, esta parte del colesterol y los triglicéridos tiene que ser medida. ¿Por qué? Porque sabemos que hay factores protectores y sobre todo que nos agregan riesgo cardiovascular. De manera específica, en nuestro grupo el HDL se encontraba en cifras de 40 miligramos de cilitro antes del tratamiento y no hubo diferencia posterior al inicio. Lo mismo para el grupo de insulina premezcla. El LDL tampoco tuvimos una diferencia, sin embargo, esto no implica que nosotros sigamos obteniendo estas mediciones. Hay que recordar que el seguimiento debe ser estrecho cada mes si no encontramos cambio, cada 3 meses si logramos un cambio significativo. Y bueno, no quiero terminar esta plática sin recordarles que las guías nos dicen que tenemos que centrarnos, hay unos goles estándares, el ciclo tiene que ser centrado en el control y en el manejo de la glucemia en el paciente con diabetes y sobre todo que esto tiene que ser un mutuo acuerdo. ¿Cuántas veces se han sentado con sus pacientes y les han dado un tratamiento? Y sobre todo, el costo. No hay que olvidar, hay terapias que son muy complejas. Nuestro paciente tiene que estar de acuerdo y tiene que entender qué es lo que es mejor para él. Hay que recordarle siempre el cambio al estilo de vida, especificar, individualizar nuestras guías, nuestras metas de hemoglobina glicosilada y sobre todo el plan tiene que ser real, a corto tiempo, limitado, involucrar a la familia, sobre todo porque no podemos sentarnos a la mesa, comer 2 tacos, un plato de sopa, cuando los demás tendrían que comer verduras. Y bueno, nuestro equipo multidisciplinario es la doctora Arellano, el doctor Tamay, su servidora, estoy dando la ponencia, el doctor. Todos estamos en el Instituto Politécnico Nacional, en la Escuela Superior de Medicina, y este trabajo y agradecimiento va para el Instituto, para el Hospital Central Norte de Pemex, que nos permitió entrar y ver a todos los colaboradores para lograr así ver pues a nuestros pacientes y hacer lo mejor posible con ellos. Muchas gracias.
Any questions to Dr. Martinez? I think however you are deliver your topic in Spanish, madam. We have got information through your slides about the topic. Any questions to Dr. Martinez? No questions. Okay. Next, we will have 5 minutes of break and rejoin the meeting again. We'll take around 5 minutes time period. Hello? Yeah. Now we ask you, Dr. Mary Slimber-Lembi from Aga Khan University of Kenya, to join the meeting and start her presentation.
Sorry. Sorry, give me a minute, please. Sorry about that. I'm connecting. Hello? Can you see my slide?
Yes, yes, ma'am.
I'm sorry about the hiccup. There was
Okay, no
I had to change in connections.
Yes, madam. Okay.
Yes, you can start your presentation.
Okay. Yeah, good afternoon, everyone. Sorry for the slight delay. My name is Mary. I'm stationed at the Aga Khan Hospital in Nairobi, and that's the hospital where I work. It's not a university hospital. It started off just as a hospital, and we recently celebrated 60 years of its existence. So I'm stationed there as a faculty in the role of assistant professor in pediatrics. This is just to show you how interesting pediatrics can be. Sometimes the doctor becomes the patient. We have several clinics scattered all over the country, 47 in all, but the main hospital is in Nairobi. That's Nairobi City. It's in Kenya, East Africa. So I'm going to talk to you about new onset diabetes after transplant, or NODAT for short. This is the outline, the nature in which my discussion will proceed. There will be a case presentation, then a discussion followed by management and a short summary. So I'll talk about a 15-year-old boy who presented to us with a one-day history of vomiting. He had intermittent fever and abdominal pains for about 4 days, poor appetite for a week. He had polyuria, polydipsia for 3 weeks, and weight loss of unknown duration. There was no history of diarrhea or constipation, chills or dysuria. In the past medical history, he had been diagnosed with end-stage renal disease several years before, managed intermittently by different nephrologists. He did not have any consistent follow-up, but he underwent allographic renal transplant 4 months prior to coming to us by his then nephrologist. There's no personal history of systemic or autoimmune disorders. In the family and social history, there's positive history for type 2 diabetes in the maternal uncle and also paternal uncle and grandfather. He had been on post-transplant anti-rejection medication for 4 months by the time we were seeing him. And this included prednisolone tablets, carbs tacrolimus, 4 milligrams once daily, and mycophenolate, mofetil. So these medications were ongoing, and we had had them, as I said, for 4 months. On examination, he was a sick-looking lad, wasted, without fever, and not pale. Excuse me. So he had some dehydration. Pulse rate was 100 beats per minute. Blood pressure normal for age at 134. Respiratory rate was a bit fast at 24 breaths per minute. He weighed 44 kilos, and as I said, he had lost some weight. This was on the 10th percentile. We had no idea what his previous weight was. His height at 177.5 was above average. but we didn't have a target range because we didn't have the parental height to calculate that. He was saturating well at room air. So the only positive physical finding was on the respiratory system and abdomen. So he had these deep respirations with a clear chest. Abdomen, just some epigastric tenderness, but the rest of the systems were okay. So we did a point of care and lab investigations. Blood glucose was initially unrecordable. After some rehydration, it could be read at 37 millimoles on the glucometer. Urine analysis showed ketones and glucose 4+. Blood gas analysis, pH of 7.1, which was severe acidosis. Bicarb was 10 millimoles and base excess was 19. HbA1c was at 12.8, so that was pretty high. C-peptide was reduced at 0.5 nanograms per ml. GAD65 antibodies were negative, and so were pancreatic islet cell antibodies. So those would be the markers for type 1. So all he had was reduced C-peptide levels. So the diagnosis was made then of new onset diabetes after transplant, or NODAT. In the management was accomplished as per DKA protocol in the hospital. The DKA resolved in 24 hours, after which we were ready to transition to basal bolus insulin, which meant glargine as the basal and boluses with Humalog or Lispro. So transition was okay, except we had quite an issue stabilizing his sugar subsequent to the transition, in that he really needed very, very high doses of insulin, as high as 3 units per kilo per day, and still he had persistent hypoglycemias despite adequate diet and correction of the high sugars. So we had issues controlling his sugar. So there was a bit of resistance. So going on into the case discussion then about NODAT. New onset diabetes after transplant, or it's also called post-transplant diabetes mellitus. This is a complication, obviously, that follows organ transplant. It can come after renal transplant or liver transplant, and is considered a secondary type of diabetes, type 2 diabetes, rather. Sorry, that one is missing there. It's been recognized for the last 50 years, and the incidence is between 2% and 53%. So it's actually quite common. It occurs equally in males and females, and is associated, of course, with poor graft function and poor survival at the end of the day if it's not well managed. So how do we diagnose then this post-transplant diabetes mellitus, or NODAT? It has to be in the presence of signs and symptoms of diabetes. We're talking polyuria, polydipsia, weight loss, plus at least one of the following. The cutoff point for hyperglycemia, as we know for diabetes, random plasma glucose of 11.1, or fasting glucose above 7.0, or 2 hours post oral glucose tolerance test of 11.1. So if they meet those criteria, then it's diagnosed as post-transplant diabetes mellitus. But it's important that we do not use HbA1c if it's less than 3 months post-transplant, because you see the HbA1c is a reflection of a 3-month history of blood glucose. So below 3 months, then we're not supposed to use it. So which are the risk factors then that predispose these children to developing NODAT? So they are the non-modifiable factors. And if you can just pick what our patient had, okay, he was of African ethnicity. He was a male recipient of a transplant, which was donated by his dad. So male donor, male recipient, those are already risk factors. There's family history of diabetes, both on maternal and paternal side. So he did have several risk factors which are non-modifiable. Then on the modifiable side, of course, he was already on anti-rejection medication. He was on tacrolimus. He was also on corticosteroids. And those are considered some of the risk factors as well. In the shared venue here, we didn't have any, and some of the ones I've not mentioned did not apply to him. So which anti-rejection drugs are considered diabetogenic? We're talking of calcinuric inhibitors and steroids. So we'll see a bit more details on those two drugs in just a bit. So what is this calcineurin or calcinuria? Sorry, it's a calcium and calmodulin dependent serine protein phosphatase. So it uses both calcium and it also relies on calmodulin, which is the molecule indicated here. This calmodulin is like dumbbell-shaped protein, and it has these two areas where it attaches calcium, so it works together with calcineurin. So calcineurin is found ubiquitously rather in all tissues. It's present everywhere more or less, and it's a very key factor in the lymphocyte activation, maturation, and also by the way of regulating the nuclear factor, which activates the T cells. So this is sort of in the step, the very initial steps of, I would call it synthesis of T lymphocytes. So it activates the NFACT cytoplasmic, which then dephosphorylates, sorry. Then that activated NFACT, you see, translocates into the nucleus. And that's now where it takes part in the gene determination and generation. It upregulates, so in the inflammatory process, rather, it upregulates expression of the interleukin-2. And then interleukin-2, in turn, activates the T helper lymphocytes and induces also the production of other lymphocytes. So as pertaining to our topic of discussion, it controls insulin gene expression in the beta cells. So that's where it actually comes in. So what is its role then in this gene expression? Now, this is the process. It stimulates the beta cell secretagogues, which then increase the cytosolic calcium concentration. This in turn then activates calcineurin, and which activates the factor that we already talked about. And this actually is crucial for the maintenance of the gene expression. So I didn't want to go into a lot of technicalities, but basically this tells us about where these NFATs are. They have several of them in the insulin gene promoter, and those are actually the areas of action and inhibition, as we see. So we're told that this gene promoter regulates proinsulin production, and it has those multiple binding sites. So the control then goes through the stimulation of the NFAT, and then that actually interferes with the gene transcription. I hope that makes sense. So disruption of that pathway at any point then would interfere with the production of insulin. And that's actually in short what I'm trying to say. Now, this diagram here just gives us an illustration of what happens in the beta cells when they sense glucose and how the process of production of insulin. The glucose comes in and then goes through the synthesis of that glucose system, and depending on the potassium channel, which is actually energy dependent, the energy produced rather, ATP going to ADP produces some energy, which now leads to the closure of the potassium channel, and that in turn then leads to the depolarization of the cell membrane. Now it's in that process now that activates the calcium channel. So the influx of the calcium channel now triggers the release of the granules of insulin that was stored in the granules. So that then happens through this bullet now of calcineurin being activated by that influx of calcium. So that is the first influx. And then after that, now we go into the nucleus to interact with the proteins in order to do the gene transcription. So phase 2 of insulin secretion will be a lot slower, because now first the insulin gene has to be secreted after exhausting already what was stored in the granules at the beginning. So that again is what happens as glucose enters through, and then the series of events through different interfaces. the potassium channel I talked about. So those are some of the areas where blockage of the processes can occur, both in the secretion of the insulin itself and in its synthesis. Okay, so insulin, initially is produced as proinsulin, okay, and then mobilized eventually and stored in the granule. So I think that's just a repeat of what I've talked about just now. Let me skip that particular cell. It just sort of puts it in diagram form. Yeah. So these are other agents, again, which are also involved in the glucose and insulin metabolism in the beta cells, generating different signals, acting at various points of contact. I think we've had another very technical speech, so I'm trying to reduce the details of this, but basically we're just saying that the stoppage, the interference with insulin production and secretion actually happens at the cellular level. So these are the three major calcineurin inhibitors. Cyclosporine, tacrolimus is used more often than pimecrolimus as well. Oops. So what's the mechanism of action then? Calcineurin inhibitors, they inhibit the phosphatase activity through the transcription factors I showed you there. So this in turn, now if you're talking about inflammation first before we go to the insulin production, reduces the production of the T cell differentiation because they act in those early stages. But in the transcription of insulin, it basically is dealing with the insulin gene, the promoter gene. So as that production, the transcription of that one goes down, then of course, so does the production of insulin. Now, these drugs, as they are used, the good thing is they cause reversible toxicity of the islet cell. So if that impact or that effect is withdrawn, then it's possible to recover. And here just says tacrolimus causes a bit more severe swelling and localization than cyclosporine. So they do have different levels of toxicity. This very busy diagram, we're just interested in this type of drugs we are interested at. Those are the areas that they block the process of insulin synthesis. Okay, so let's talk a little bit more about tacrolimus. So once it binds to its intracellular receptor, immunophilin, then that complex binds to the calcium phosphatase and then inhibits the transactor. This inhibition then prevents the dephosphorylation of NFACT-C and its subsequent relocation to the nucleus. And that, of course, as I said earlier, limits the transcription of the NFACT-C dependent genes. So in other words, then it inhibits the synthesis and the secretion of insulin. So these effects are time and dose dependent and they're reversible. Tacrolimus induces post-transplant diabetes mellitus, but after withdrawing the drug, then those effects can be reversed. Unfortunately, of course, if we are talking about a patient who's had transplant, they are virtually dependent on these drugs to maintain the functionality of the transplanted organ. Now we find that cyclosporine, on the other hand, affects both the release and even the sensitivity to insulin. So acting more like a type 2 diabetes where the sensitivity to insulin is reduced. There's racial differences in reaction to this, regardless of the dose of the medicine. We find that African Americans are more susceptible, for example, compared to Caucasians, even if they're on similar doses. That's corticosteroids, or even if the trough levels of tacrolimus are low. So those again are multifactorial. It's not really always explained in one way. There are also individual differences even within the same race. So depending on course how they handle the drugs, their pharmacokinetic profiles, and so on. So trough plasma per se, that's to say, will not really guide us as to the amount or the actual dosing for any particular patient. How about steroids? How do they come in? So basically, they induced increased cellular concentration of the gluconeogenic enzymes. In other words, they actually act contrary to what insulin would do as direct antagonist. They increase the hepatic glucose output from gluconeogenesis and also glycogen lysis. You know that insulin is very busy building up glycogen. These guys come in to destroy, or rather to break it down, so causing a lot of inflated sugar levels. They also reduce glucose uptake by fat and muscles, so there's no storage of glucose at all. So starting with cortisol, it inhibits glucose uptake by the muscle. It also breaks down the protein, so giving you one of the raw materials for gluconeogenesis, these are amino acids. It activates lipolysis, so increases the free fatty acids, so there again is another raw material for gluconeogenesis. Now, chronically, it will induce gluconeogenic enzyme synthesis. So there'll be more enzymes on board, more glucose to use, and of course, increasing the glucose levels in the process. So it increases glucogenolysis in the liver and also in the muscles by activating the glycogen phosphorylase by epinephrine and norepinephrine and glucagon. Sorry about that. So basically this, again, I like diagrams because they give you in a visual form what we are trying to talk about. So this is what insulin would do, but now in the process of glycogen being broken down, the equation is actually refers to production of more glucose in the blood. So all these feeders are actually now going in the opposite direction. So which hormones are involved? We mentioned glucagon, which is released from the pancreas, and this is triggered by hypoglycemia. It's a dropping, of course, glucagon comes into play and promotes the process that we've just looked at. So epi and norepinephrine, these are released, as we know, from the adrenal glands, triggered by stress or any threat, something coming to scare you, your adrenals come into play and release some of these hormones. Cortisol, again, also from adrenal in response to stress. Stress can be of different kinds. Even sickness itself is stressful, or even mental stress. So these are the hormones now behind the processes that we've just seen, and increasing the glucose concentration in the blood. Don't worry too much about this busy diagram. It's just, again, illustrating what I've talked about. So what evidence do we have from studies about new onset diabetes after transplant? So it's been seen that administering tacrolimus to non-diabetic dialysis patients resulted in a dose-related reduction in insulin secretion. So that was one of the pointers that actually tacrolimus does have an effect on insulin production. Patients who developed post-transplant diabetes already had some impaired glucose metabolism pre-transplant. This is not always true, but some patients actually did have normal sugars and they still go ahead and develop post-transplant diabetes. Now, in another study, corticosteroid withdrawal from tacrolimus-based immunosuppression reduced insulin resistance without changing insulin secretion. So that basically tells you corticosteroids were working more at the resistant level, the cell reception to the insulin or sensitivity to the insulin. Now, again, reducing TAC blood levels by 30% within the therapeutic window increased the insulin and C-peptide secretion. We already went through what tacrolimus actually does. Yeah, so those were some studies that actually have confirmed that point. Now, similarities between NODAT and type 2 diabetes. Both of them have gradual in onset. Somebody might actually not know that they're unwell, unless, of course, the blood sugars are tested. Then you note that they have some hypoglycemias. They may be asymptomatic for years, which is quite different from type 1. Type 1 usually has a dramatic onset. Hypoglycemia or diabetes is not always permanent, as I said before. If the triggering condition is controlled or the drugs are reduced, you might be able to actually reverse the symptoms. Risk of developing the condition increases progressively for the remainder of the patient's life. So one can never say, okay, this post-transplant patient is now free of possible side effects of these drugs, of development of diabetes. So they really have to be monitored continually for a very long time. Okay, then, so what measures should you put in place to make sure these patients are safe, or at least that we preempt anything that might happen to harm them? First of all, before transplant, of course, we want to screen the patients for any risk factors that we already went through before. We want to monitor their fasting blood glucose. We just seen that patients who have pre-existing hyperglycemias are more at risk. So we want to make sure their blood sugars are okay. Do they have any other cardiovascular risk factors that need to be taken into account? And of course, counseling regarding the risk of developing diabetes after transplant has to come on board. If they have any lifestyles that need to be changed, addressed, those ones should also, they should be counseled about. Dietary, and lifestyle. If there's a lot of, how do you say, they're lazy or they're not having adequate exercise, so that should be put into practice as much as possible for healthy living. So then post-transplant, what do we do? Of course, they have to be monitored regularly. All patients should be on regular monitoring. Their fasting glucose is measured weekly for the first 4 weeks. After that, every 3 months, every 6 months, and then yearly subsequently, if they remain stable. HbA1c is done every 3 months after transplant, the way we do for the people with diabetes. Consideration of immunosuppressant therapy modification without, based on impaired glucose tolerance, without, of course, compromising their stability. If there are any accompanying comorbidities, cardiovascular, they should be aggressively managed to lower any further risk. So ideal dose of corticosteroid is still an ongoing debate, discussion. And again, of course, all treatments are very individualized, so you can't have one size fits all. It has to be on an individual basis, but we want to go with the minimum really that is needed to maintain stability in this patient rather, and forestall complications. So a study has shown that prednisolone dose more than 1.3 milligrams per kilo per day was associated with a higher risk of renal, of patients who developed diabetes after renal transplant. 5 milligrams per kg per day rather is the recommended dose. The production of cortisol is about 10 milligrams per day. But if they go at this dose, generally they would be safe. But nonetheless, of course, you have to go with what makes the patient stable. And if there is diabetes mellitus, then we have to treat it. Treatment of NODAT is a stepwise approach. So possible as we treat diabetes, again, we start with diet, depending, of course, on the level of blood sugar. The patient I presented actually came in DKA, so there was no gradual approach there. The approach was, the presentation was like type 1 with all the drama, but without the antibodies of type 1. The weight reduction exercise, I've already said that if they're overweight, they need to have a healthy lifestyle, reduce their weight. Then we start first with oral monotherapy. It's assumed actually that NODAT would respond to oral hypoglycemics. But we've seen cases also where the C-peptide is actually reduced. So some of these patients would require insulin right from the word go. So we would not want to first try oral monotherapy and then go on to insulin later on. So insulin, again, we don't really want to delay providing it. So long as the patient needs it. You don't really want to wait for metabolic decompensation. Going back to our case, I'll just mention that, as I said, he needed very high doses of insulin. And as much as he was getting controlled on that, we had to bring in metformin. And with that, actually, the dose of insulin required eventually went down. So he was needing as high as 3 units per kilo per day, which is actually very, very high. Eventually, we were able to come down on his insulin requirement, but he needed metformin for a while. Of course, we were keeping an eye on renal function. You want to avoid metformin because of the risk of lactic acidosis. But here's where you are caught between a rock and a hard place, and we just wanted to make sure at least his renal function was okay before that came on board, because otherwise his blood sugars were not controllable. So the adjustment of immunosuppressive therapy, of course, should be considered without putting the patient at risk of rejection of the graft. We reduce the glucocorticoid doses as soon as possible. Usually you don't really completely withdraw. I said we try, if you can maintain them on 5 milligrams per day, that would be the recommended one, if possible, by 1 year, but some patients actually need their drugs for much longer. You'll always be guided individually by the response of the labs, patient status. So then how do we follow up these patients? Quarterly, that's every 3 months, HbA1c and lipid profile. Twice or thrice a year, we do their microalbuminuria. Normally, when we're screening for complication for the other diabetics, it's like once a year, unless, of course, they're already in trouble. Yearly ophthalmology review, basically looking for complications, diabetes, and of course, the FET exam, as we know. For HBO, those children now, those are the patients, because I'm a pediatrician, I'm sorry I keep talking of children, so you bear with me. There are patients with HbA1c below, above 6%. Of course, they have to do their home monitoring of blood glucose, quarterly HbA1c like anybody else, and no additional therapy beyond diet and exercise. Until now, the HbA1c goes up to 7%. But you remember I told you in the first 3 months, this will not be our criteria for diagnosing, no that. It's more for monitoring. Now, those who had perioperative hyperglycemia, of course, they still also have to regularly monitor their blood sugars and maybe start an insulin injection if that's needed. So what's the treatment rationale? Basically, to reduce complication risk and also chances of rejection of the graft. Because the poorer the blood sugar control, of course, the more at risk their kidneys are as well. So in summary then, post-transplant diabetes mellitus is a significant cause of morbidity and mortality in transplant patients. There are certain risk factors, some of which can be modified. Screening for early identification is recommended. The early identification of such conditions, in addition to a thorough treatment of diabetes and its comorbidities, will determine, of course, the progression of the disease. And then dose adjustment of immune regulators may be useful in the final run. Thank you for your attention.
Yes. Like any questions to Dr. Mary Limbe? Any questions? Thank you very much, madam. Thank you very much for speaking this meeting and providing a unique perspective. Thank you for sharing your tips with us. Looking forward to the next event.
Thank you for inviting. Thank you.
Yes. So now we ask you, Dr. Mahmood Asif Rashid from Komasats, University of Islamabad of Pakistan, to join the event and start presentation.
Hello everyone. I hope all of you can listen me properly. Am I right?
Yes, sir. So just you can enlarge the screen, sir. It's be clear to your one. Yes, it's fine.
Okay. Myself, Dr. Muhammad Asif Rashid. I'm working as an assistant professor at Department of Biosciences, Comsats University, Islamabad, Sahiwal campus in Pakistan. The topic of my presentation is inhibition of 2C Coxsackie B virus protein to decrease pathogenicity of diabetes mellitus type 1. So, as all of you know, that there are major two types of diabetes. It can be insulin dependent or insulin independent. Uh, this hyperglycemia has many causes. So, for example, genetic predisposition is there. If the person has history of history of diabetes in the pedigree, in the grandparents, in the parents, so most probably the predisposition is high in the particular person. Another one is immune system. So if the immune system is going to attack the beta cells, then the disease will occur. And the third one is environmental factor. So I'm going to talk about on this particular environmental factor. Uh, there are many symptoms of diabetes, for example, polyuria, polydipsia, weight loss, and polyphagia. So as far as the environmental factors are concerned, one factor, one environmental factor is Coxsackie virus B4. This virus is supposed to target the beta cells of pancreas, and the virus is going to destroy the beta cells, thus causing the uh, hyperglycemia and decreased production of insulin. This particular virus belongs to picornavirus family, and these are small RNA viruses. This virus is single-strand RNA genome, so that's why mutation rate is also high in the virus. So the objective of this project was to predict the protein structure for this particular virus using different computational tools, uh, and also to predict the compounds against this particular virus. So this project was based on bioinformatics analysis and different tools related to bioinformatics. So at the end, we were supposed to find some uh, best compounds which can be effective against these types of viruses. So this is the workflow for this particular project. First of all, the protein sequence for this viral protein was retrieved from UniProt database. The structure of the protein was not there in protein database. So the structure was predicted by ITaser. Uh, then the inhibitors for this particular protein of the virus were predicted by drug bank and PubChem databases. The predicted inhibitors were checked in MQL and ADMETSAR for different properties of these inhibitors. Furthermore, the energy minimization of the protein was done by Chimera. And after that, the docking analysis was performed for these inhibitors against the protein through Autodoc Vina. And the virtual screening was performed on the basis of the generated pharmacophore modeling, and this generated pharmacophore was used for virtual screening, and then we got some novel compounds, uh, and we filtered these novel compounds on the basis of the docking, and at the end we found some lead compounds. So at the end we got 2 lead compounds in this project. So this is the structure of the protein. The quality of the structure, predicted structure, was 86%, which was checked by Ramachandran plot. So These are two-dimensional chemical structures of the inhibitors before the visual screening. So some inhibitors which were against these particular protein were selected initially. So these are two-dimensional structure of around 10 inhibitors. So the adversarial properties of these compounds or these inhibitors were checked, and here different uh, characteristics of these compounds are given. So on the basis of these inhibitors, uh, can you listen me?
Yes, sir. You have been disconnected, sir. Just you can.
Yeah, I think there was some internet issue, so I think I'm connected again now.
Yes, yes.
So let me start again.
Yes, yes.
So I was here, I think I have shown the docking results for these different inhibitors, and then you can see the docking complexes for these inhibitors. Right now, we had the 5 docking compounds.
Excuse me, sir.
So,
Just you can upload your PPT, sir. PPT has not on the screen.
okay, so you want to upload it?
It's up to
Should
you,
I
sir.
stop
It's up
sharing?
to, it's up to you.
Yeah, if it's working, then I think we can go on with this setting, I think.
Yeah.
Okay, so here we are going to see some protein and ligand interaction results. The protein and ligand interaction results for 8 compounds, and on the basis of the docking, you can see that we performed the virtual screening on the basis of pharmacophore, and the virtual screening highlighted some significant compounds at the end. So these are the compounds which we got at the end, and the next step was to perform the docking with these selected compounds and to check the highest binding affinity among these compounds. So on the basis of the binding affinity, we selected the 2 compounds, as you can see here, and different properties of these 2 compounds are given here, and similarly the admit properties for these lead compounds are given in this table. The interaction for these 2 compounds against the protein are given here, so you can see that uh, this is the compound of the protein, and
Excuse me,
this
sir.
is
Sir, we are not able to see your PPT, sir.
oh, okay. So then
Shall I play behalf of you on?
okay, you can play. Okay,
Yeah, yes, sir. Just play.
maybe I think I have some internet issue here, so not so good internet here because I am in the remote area.
Okay, just
Maybe
play.
that's why. All right. So can you please move to the second last slide? I think I was there.
Okay.
Yes, please here. Yes. So
Okay, sir.
yes. So these are the interactions which are shown against the particular protein. The interaction of the protein with the ligands are shown. For example, we had two lead compounds at the end, and the interaction of the left hand side. The zinc ID of these two compounds are given. The left hand side, on the left hand side, the compound is interacting with the protein through lysine, while on the right hand side, the compound is interacting with the protein with histidine. Next, please. So in this project, we first of all, we predicted the protein structure of the virus protein, and then we found the selective inhibitors for this virus. So then we filtered the compounds on the basis of the binding affinity, and at the end we got two lead compounds, and we believe that if we are going to use these two compounds, maybe the environmental factor which is based on this virus, maybe the pathogenicity of the virus is going to be decreased. Next, please. Thank you very much. If you have any question, you are welcome to ask. Right now, we could not confirm the results in the lab. So this is the next step, that we can confirm the affinity of these compounds against the virus. So we can use it to check either how much these compounds are effective against the virus. Thank you very much.
Yes. Any questions to Dr. Mohammad Hasif Rashid? Any questions? So we got a message from Dr. Ravi Puperla. Good presentation, sir, to you.
Thank you very much.
So thank you very much, sir, for speaking up in this meeting and providing a unique perspective. Thank you for sharing your tips with us. Looking forward to meet you again next time. Now we ask Dr. Isaac John of Umrah from Federal University of Nigeria to join the event and start presentation. So just you can enlarge the PPT.
Yeah, okay. Okay. Good evening, ladies and gentlemen. I'm Dr. Isaac John Omaro, staff of Federal University of Wukari, Nigeria. I'm here to present my paper titled Chemical Constituents, Cytotoxicity, and Hyperglycemic Effect of the Leaf of Selenium nigrum L black nightshade. The outline of my presentation goes like this: general background, methodology, result and discussion, then finally conclusion. Introduction. The World Health Organization defines traditional medicine as practices, knowledge, and belief system which use mineral plants and animal-based remedies to treat and maintain well-being. Well, in my own humble self, I define traditional medicine as a spiritual therapy, an exercise to prevent, treat disease and ailment for better health. Plants, being the most reliable source of food to humans, have also been used as folk medicine for centuries and as medicinal remedies in healthcare system, even with the advancement in technology. The plant of interest, Selenium nigrum, commonly known as black nightshade, belongs to the family of Solanaceae, and it is also called garden nightshade. The plant commonly grows as a weed in most habitats and can be cultivated in tropical and subtropical environment by the seed. The leaves, which is our main concern in this research, are used for rheumatic and gouty joint, skin disease, tuberculosis, nausea, and nervous disorders, as well as cough and diarrhea. The eternal extract was reported to have anti-cancerous properties. However, diabetic is a disorder due to either the pancreas not producing enough insulin or the cells of the body not responding properly to the insulin produced. There are two main common types of diabetic mellitus, commonly called as type 1 and type 2 diabetes. Therefore, this study was conducted to isolate the chemical constituents, evaluate the cytotoxicity, and the anti-diabetic potentials of the leaf of Selenium nigrum, commonly called black nightshade. Since we are virtually looking at the potential effect of this plant part, which is the leaves, in containing the potentials as regards in the treatment of diabetics, I would like to highlight the main symptoms of diabetics in humans. In the central nervous system, we have what is called the polydipsia as one of the symptoms one can commonly identify in a diabetic patient. Secondly is polyphagia and lethargia. While in the eyes, we have these symptoms of blurred vision. Coming to the oesophagus, the breathing smell is of that of acetone. And generally, the common symptoms you will see in a diabetic patient as well is the weight loss. Related to the kidney, which is the urinary, we have polyuria and glycosuria. Coming to the stomach, we have these common symptoms of nausea, vomiting, and abdominal pain when it comes to diabetic patient. And finally, we have frequent urination, which can simply identify or which clearly shows to a common man that this person may likely have diabetics based on these symptoms mentioned. Therefore, in our studies, We use these protocols to determine the potential activities of our plant extract. The dosage of the sample for the study were prepared, and the fusion of the extract were given to the rats orally by cannula. However, rats which died as a result of induction of streptozin administration were simply disposed of, and the cage were changed within 3 to 4 days of the start experiment. In the experiment protocols, the rats were divided into 9 groups each, containing 8 animals. Group 1, which has the normal non-diabetic rats. Group 2, which has the diabetic rats as control, while group 3 and 4, which has the control with glycylchlamydia and glypenclamide and pioglitazone at 600 microgram per kg and 429 microgram per kg respectively. While group 5 to group 9 are the diabetic rats treated with different concentration of crude extract as well as the isolated compound called campesterol respectively. This is the flow chart of the protocol taken during this study, where the selenium nigrum leaves crude extract was, excuse me, sorry, where the selenium crude extract was subjected to cytotoxicity to ascertain the toxicity of the leaf crude extract, and then the subjection of the crude extract to column chromatography to isolate the chemical constituent of the plant. In these studies, we were able to isolate compound called campesterol, which is shown in this chart, a single peak indicating that this compound is a pure compound isolated from the leaves, going through the protocols of isolation and characterization. This isolated compound is subjected to the nuclear magnetic resonance to ascertain the hydrogen and the carbon of the compound as far as characterization of the compound is considered. As such, from there, we subject this compound to FTIR, Fourier transformer infrared, to look at the carbon and hydrogen and some of the compounds composed, some of the elements composed in these isolated compounds. From there, we subjected this crude extract and the isolated compounds to the induced diabetics, to the induced diabetic rats using streptozin. And in the course of that, we came up with this result, which shows one, I made mention of the cytotoxicity of the plant, which result is presented in table 1. From there, I'll go to the effect of this plant on the induced diabetics as a result of the streptozin effect. In the cytotoxicity, in ascertaining the cytotoxicity of this plant, we tend to find out that different crude extract from different solvents shows different cytotoxicity, which is indicated in the red column. And we come to find out that campesterol, which is being isolated from the nigrum, selenium nigrum leaf was found to have higher cytotoxicity effect with 18.48 microgram per mil when compared to the other crude extract from hexene dichloromethyl chloroform in an ethyl acetate extract. This shows that campestrol have higher cytotoxicity compared to the crude extract from this solvent. From there, knowing the cytotoxicity potential of this plant, we tend to subject this two group of samples, which is the crude extract and the isolated compound, to look at the changes on blood glucose in the induced diabetic rats. So table 2 is giving us the parameters, the control, diabetic control, and the two common drugs used for the treatment of diabetes in comparison with the result obtained from the crude extract of selenium nigrum. And based on the concentration, we also found out that a good change was obtained at 500 microgram per DL, looking at the parameter and the pretreatment based on time. We found out that at day 21, the post-treatment gave a very good changes of blood glucose in the induced diabetic rat with 98.11 plus or minus 4.67 microgram per DL. So this result is telling us that the crude extract is very potential or significant with increase in concentration of the crude extract. Since at day 7, we have 184.78 microgram per DL, and day 14 is giving us 129.45 microgram per DL. Then day 21, at the same concentration, which is the highest concentration here, is giving us 98.11 microgram per DL. This shows that with increasing concentration, the selenium nigrum crude extract has a very good significance in reducing the induced diabetics as a result of streptozotocin. Looking at the changes on the body weight of the induced diabetic rats, we observe that at the same high concentration, there's a significant increase in the body weight at day 21 post-treatment with 223.14 microgram per day. So we tend to look at the isolated compound, which is the petestrol, the potential effect of this isolated compound on the induced diabetic rats. We also found out that comparing the days interval, like in day 7, the post-treatment is giving us 236.12 milligram, plus or minus 1.34. And at day 14, with higher concentration of 500 milligram per DL, we also observe that there is an increase in the body weight of the induced diabetic rats. And coming down to day 21, shows that with increase in concentration of this isolated compound, campestrol, we've also found out that there is an increase in the body weight of the induced diabetic rats. So looking at the potential of this isolated compound on the blood glucose level of the induced rat, we find out that campestrol also has a significant reduction in the blood glucose level with a range of at 21 days with 73.09 microgram per DL compared to day 14 and day 7, which shows higher at the same high concentration. I tend to choose the higher concentration to elaborate on this study because a result indicating the significance of these two samples, which is the crude extract and the isolated compound. And we tend to find out that these two compounds act effectively in reducing the blood glucose and increasing the body weight of the induced diabetic rats. So in essence, comparing the isolated compound and the crude extract as regards the lowering of blood glucose level in the induced diabetic rats, we found out that campestrol has higher significance compared to the crude extract, which invariably shows that campestrol is one of the compound constituent in this crude extract that is responsible for the reduction in the blood glucose level of the induced rat. So as earlier said, that campestrol shows higher changes on the body weight of the induced rat based on increase in concentration and then increase in time or day of post-treatment. Therefore, we tend to conclude and come with this postulation that it is possible that the action of the crude extract and the bioactive compound, which is the campestrol and the medicinal plant on solugram, has this effect, which gives the impact of a carbohydrate reduction in blood glucose. Going by this chart, we tend to present the therapeutic effect of these extracts on diabetics. That is by activation of the adenosine monophosphate kinase pathway, beta cell number of the pancreatic islet, and the insulin secretion, which invariably reduces the impact of carbohydrate on blood glucose. Going to the other side, showing the isolation of this campestrol, we also postulate the possibility of the campestrol being a steroid inhibiting or showing an inhibition of glycogen phosphorylase or glucose 6-phosphate, which in essence reduces the impact of carbohydrate on the blood glucose. We also postulate that inhibition of this activity against alpha glucosidase will tend to reduce the impact of carbohydrate on blood glucose. Likewise, the inhibition of this campestrol on lipid peroxidation, stimulation of the insulin secretion, and protective and regeneration of the beta cell function. With all this activity, and with the significant potential of this isolated compound and the crude extract, we relate to this chart, which conclude that activities of these two samples undergo these patterns to reduce the impact of carbohydrate on blood glucose. In conclusion, it has been found in this study that during the course of this work, that Selenium nigrum is a potent medicinal plant, and campestrol isolated from this leaf's crude extract of Selenium nigrum has proven itself to be nature's extraordinary therapeutic agent, and attention should be spent on developing it as a substantial, sustainable drug for prophylaxis and treatment of complications such as diabetes and other diseases. Thank you for your attention. Hello?
Yes, yes.
Yeah, expecting questions if there's any.
Any questions? Any questions to Dr. Isaac John? Thank you very much, sir. We have enjoyed your speech. Pleased with your topic. Looking forward to meet you again next time. Now we ask Dr. Mohammed Ridwan, Minister of Health, Palestine, to join the event and start presentation.
Thank you.
Hello.
Yes, sir. Just to be honest.
Hello. Hello.
Yes, sir. Just be online. We are going to enlarge your PPT. So you can continue your talks. Hello.
Hello.
Yes.
Can I start?
Yes, sir.
Okay. Are you hearing me?
Yes.
Hello. Okay. I will start. Hello, everybody. I am Dr. Mahmoud Radwan from the Palestinian Ministry of Health. Thanks for our colleague for arranging this important conference. To save the time, I will start. My title is medication adherence associated factor among patients with type 2 diabetes mellitus in Gaza Strip, Palestine. I will not go to the global figure, but I can say that diabetes mellitus is a global public health issue in Palestine, mainly in two main regions, West Bank and Gaza. A recent report showed that the prevalence rate of diabetes mellitus was 15.9% in West Bank and 12.9% in the Gaza among the registered Palestinian refugees aged 14 years and older. And it has been projected in a recent report also that the prevalence of diabetes mellitus among Palestinians will be about 23.4% in 23. I can say that in Palestine we did well with communicable diseases, our classic enemy, and now our new enemy is the non-communicable diseases, particularly diabetes, cancer, heart diseases. Next, please. Methodology. Actually, I employed a cross-sectional analytical design, and the setting was in Gaza. In Gaza, we have five governorates, and we implemented our study in 9 primary health care clinic, level 4. And why we selected level 4? Because in Gaza we have 4 levels. 1, 2, 3, 4. The fourth level is include advanced services and variety of services like there is ultrasound, X-ray machine. In the other levels, you cannot see this. And besides this, you can see more number of doctor and nurses. It is large clinic. The total or the study population included 6,486 type 2 diabetes milliliters. Next, please. The sampling. The sampling, as I said, in Gaza, we have 5 governorate. I use a cluster simple randomization. I try to simply, and by randomization, select one primary healthcare level 4 from each governorate. And when I try to select the eligible participant, I used proportionate, stratified, systematic sampling. Proportionate because we have different number of diabetes mellitus in each primary health care clinic. At the beginning, I tried to stratify the list of diabetes, the registered diabetes mellitus according to gender, and I tried to select the 17th patient from each clinic. 17th because it is systematic selection, because we have I divided the total population by the sample size, and by the way, the sample size was 372. Next, please. The calculated sample size, I used the standardized formula, and the calculated sample size was 338, and I did 10% for non-response rate. So the total sample size was 372 diabetic patients. Next, please. Eligibility criteria, I tried to include all diabetic patient type 2, not type 1, and all the ages above 30 years old, who, for those who under diabetic therapy for at least 6 months at the time of data collection. And I included all the person or the participant who has had the willingness to participate in this study. I tried to exclude all pregnant women with diabetes and all patients with diabetes with mental diseases. Next, please. Data collection. I tried to use self-developed questionnaire after reviewing the relevant previous studies, and I used many questions from different standardized questionnaire. So it was self-administered questionnaire and structured questionnaires, and the questionnaire included 5 parts. The first one is socio-demographic and disease history characteristic, which include age, gender, place of living, duration of diabetes mellitus, complication like cardiovascular disease, retinopathy, retinalpathy, neuropathy, and the last one, previous hospitalization. The second part, which is very important, is the health belief model. I tried to use this model, which has been widely used in healthcare system, to see how the people are, how their attitude or their belief can affect their commitment to adherence or compliance with treatment. This health belief model included 16 items, and these 16 items are distributed on 4 main parameters. The first one is perceived sustainability, susceptibility, and perceived severity, and perceived benefit, and perceived barriers. These items I used Likert scale, which range between strongly agree, which took the value of 5, and strongly disagree, which took the value of 1, and the cutoff point was equal to 3 or above. This means that if the score was equal to 3 or above, that means that the participant had or has a good or accepted belief or positive attitude. The second, hello, 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 are you
Yes,
hearing
sir.
me?
Yes, yes.
Hello.
Yes, sir.
Okay, thanks. The second, okay, thank you. Okay, the second part of my questionnaire, which included the questionnaire of patient-physician relationship. And this questionnaire included 10 items. And these items I used also Likert scales, which range between the responses of strongly agree and strongly disagree. Strongly agree, which took the value of 5, and strongly disagree took also the value of 1. The fourth part of my questionnaire, I used the brief health literacy scale, or brief health literacy screening scale, which include or encompasses 4 items. And these 4 items also I use the Likert scale, which included always, which has took the value or the value of 5, and never, which took the value of 1. The fifth part, I used Morsky medication adherence scale. This is the commonly used and well-known scale, and included four items. And the scale was based on a dichotomous scale, that means that which included yes or no question. And the sixth part, which maybe not included here, I tried to use primary outcome to measure the primary outcome indicator, which was the glycemic control. In this study, I tried to take sample from all my participants. I collected blood sample from them, and I measured the hemoglobin A1C. So the hemoglobin A1C was the primary outcome, but medication adherence was the secondary outcome. Please. Data collection. The questionnaire was translated into Arabic and validated following the translation steps given by the Agency of Healthcare Research and Quality. At the first step, I tried to use forward translation from English to Arabic, and then backward translation from Arabic to English. Then I tried to validate this questionnaire by expert review, and then I did piloting for the questionnaire. Actually, also a trained interviewer collected the required data by face-to-face interview, and data collection took place during patient visit to the primary health care, and the time average was about 15 to 20 minutes, and it was enough to complete the questionnaire. Next, please. Validity and reliability. Actually, I used 9 health experts to validate my questionnaire, and these experts from various and different background: academic health expert, public health expert, and endocrinologist like this. And I try to validate the content and face validity through determination of item content for the content item validity. I try to measure the item content validity index and scale content validity index. The item content validity index range between 0.88 to 1, and the scale content validity index range between 0.97 to 1, and this is very good content validity. And also I tried to check the internal consistency of the entire questionnaire to examine the Cronbach alpha, which was very good, 0.7. And also for the reliability, I used inter-rater reliability, which measured by kappa statistic revealed, and which revealed a high agreement between the Rhine rater, which more than 0.85. Next, please. The result, next, please. Okay, thanks. This slide shows the social demographic. Next, please. Next, please. Okay, this slide shows the the slide before, please. Yes, thank you. The socio-demographic characteristic and disease history. The age of my sample of the participant, the mean age was 56 plus minus 10. 13% were less than 45. half of my sample was their age was between 45 and 60, and 35% were above 60. Regarding the gender, 55% were female, and the overwhelming vast majority were married, and the mean age duration of the diabetes mellitus was 8 years plus minus 8. The complication, 55%, they hadn't any complication. The pre-hospitalization, the vast majority, 88%, they didn't go to hospital for inpatient hospitalization. Regarding type of medication, most of the participants, they were in oral antidiabetic. 23 of the participants, they were in insulin, and 11% they were in both oral and insulin. Next, please. Okay. The Morse scale showed that the medication adherence, 58% of the participants were highly adherent to their medication, and 38 they were moderately adherent, and 2.5 were low adherent. Next, please. Next, please. Okay. This slide shows that the mean of influencing factor, according to the health belief model, the mean of this model was 3.6, which is good, above the recommended cutoff point. This means that the patient has relatively good attitude toward their disease or their medication. And the second parameter, physician-patient relationship, it seems that the mean was 4.5, which is very good. This means that the trust relationship between the doctor and or the healthcare professional or physician, doctor and the patient was good. The problem was in the health literacy, which shows that the mean was less than 3, which was 2.9, and this is below the recommended cutoff point. Next, please. Glycemic control, which is the primary outcome after we collecting the blood samples and measure the hemoglobin A1C. We found that the overwhelming vast majority of the patient, they had like 98.9% of them, they had not good hemoglobin A1C, which was above 6.4%. Next, please. Okay, when we went to show the most factor affecting the medication adherence, we did logistic regression, and we found two variables which was associated with the adherence. The first one is gender. The female were more adherent to medication adherence than male, and this was associated with the adherence with odds ratio 1.6. This means that the female was 1.5 times higher adherent to medication. The second variable is the attitude, the severity, how the patients perceive the severity of their disease, which was also associated with adherence 1.5, one time rather than or higher than the people who perceive less their disease. Next, please. Okay, when we did multivariate analysis, we found also two variables that can predict the factors that can be associated with the adherence to medication. The age, the higher age, above 60 years, they were more adherent, and the duration of diabetes, the patient who had more than 10 years of their disease, they were more adherent, but this association was not significant. Next, please. Limitation in each study, there is limitation. We relied on self-reporting, and the self-reporting has its strength and limitation. You know, the recall bias sometimes and social desirability bias, and selection bias. Some we selected like level 4 primary healthcare. We didn't go to the level 3 or 2 or 1. Maybe we can find different findings. And the last one, reasons for non-adherence were not addressed in the study because we didn't use a qualitative study or focus group or in-depth interview, so we can dig beneath and find more factors that can related to the non-adherence for the patient medication. Next, please. Recommendation. We have this recommendation. We can suggest to address patient belief about the severity of disease, the benefit of the treatment. The second, the diabetes health education to improve patient adherence to their medication through patient self-management of diabetes, meeting with the diabetes educator on a regular basis, use of educational materials, establish a community campaign, improve the communication between patient and healthcare provider, and the last recommendation to conduct more studies on other main predictor of that can affect patient adherence to their medication. Next, please. I think this is the last one. Thank you so much, and I hopefully I didn't exceed my time. Thank you so much.
Yes. Any questions?
Any question?
Any questions to Dr. Mohammed Radwan? Thank you, sir. We have enjoyed your speech. Pleased with your topic. Thank you very much. Looking forward to looking forward to meet you again next time.
Thank you. Thank you.
Yes, sir. Now we ask Dr. Shakil Ahmad from University of Kiri, Ireland to join the event and start the presentation. Hello. Hello. Sir, just we have more one talk that will be Dr. Shakil. So just we'll take a 5 minutes break and we'll rejoin the event. We'll take 5 minutes break.
Can you hear me?
Yes, sir.
Hello.
Can you hear me now?
Yes, sir. Just let's wait for 5 minutes, sir. We had just now we had given break.
Okay, that's fine.
Yes.
So how I can move my slide you will move the slide or I should move the slide?
No, I just you can mention the word next. I'll be moving from my side, sir.
Okay, that's fine. That's great.
Hello.
Hello.
Yes, sir. You can start your presentation.
Good afternoon. I'm Dr. Shakil. I'm working as a endocrine registrar in the Regional University Hospital, Limerick, and the research project which I have done, it was in University Hospital Kerry. So University Hospital Kerry is actually situated in the southwest coast of Ireland, and it is it's a beautiful tourist place. I worked there almost 18 months there, and I was working as a endocrine and the medical registrar there. So, and that project I have done there, and with me, some of my other colleagues were Dr. Simon Corkin was my SHO, and Dr. Tom Hagan was my consultant. So the topic of my my article or research was a risk of renal deterioration with SGLT2 inhibitors in normal or risk group with type 2 diabetes. So we can move forward. So as we know, type 2 diabetes is a very prevalent and preventable chronic disease. It arises from insulin resistance and relative impairment in insulin secretion. And it has a lot of comorbidities, nephropathy, retinopathy, and neuropathy, and it can predispose to and exacerbate the cardiovascular disease. Next, please. So SGLT2 is a relatively new drug, and it is significantly more famous nowadays. As if we go through the mechanism of action of this drug, so mainly the drug bind to the receptor of the proximal tubule and block the receptor. As a result, the glucose reabsorption, the proximal tubule is inhibited, which result in the excretion of the glucose with water. So it decrease it decrease the glucose absorption and also help in the excretion of the water. So it has a diuretic effect plus controlling the blood glucose. So this is the main mechanism of action of this group. So SGLT2 is not usually we use as a since first line therapy. It is mainly used as a second and third line therapy, and basically we are using when the metformin is failing, and then we can add as an add-on therapy, and a lot of combination in the market at the moment is available with metformin with SGLT2, and it is very famous also. But with other groups like SGLT2 and DTP4 and sulfonylurea, we can add as a second or third line therapy. when anyone is planning for starting SGL2, so baseline hemoglobin H1C, renal function, liver function, and intravascular volume should be looked very carefully, and after that, every 3-month assessment can be carried out to see if any adverse effect is noted in these patients. So we can go to the next slide. So see the adverse effect of what are the adverse effect we can carefully look in these patients as the patients as there is a lot of excretion of the glucose happen because of the mechanism action we discussed early. So recurrent urinary tract infection is one of the, and especially the mycotic infection is a side effect, and there is a risk of the DKA we call is a euglycemic DKA, because as the glucose absorption is decreased, there is a endogenous requirement of insulin, or exogenous requirement is decreased, which result in the absorption of the ketone from the kidneys. So as a result, these patients can develop a euglycemic DKA. Also in 2015, the FDA have warned that these patients, those who are taking SGL2, they are risk of the amputation and the fractures. So any patient who's admitting for the procedure or hospitalization after the fracture, so it is advisable to stop prior or after, during the hospitalization, or after 2 or 3 days after the hospitalization, once the patient stabilized. Also, though, looking for any patient who's starting with SGL2, the renal function at the time of the start and later the deterioration is important. And if it is less than 60 eGFR, the dose adjustment is needed. If it is less than 45, which is usually not recommended. The next slide. The next slide, please. So we have randomly selected and analyzed patients in our clinic, which are turned up in our outpatient clinic in University Hospital Kerry, and it is in between May to June. And these 75 patients were selected on the criteria that they are on the SGL2, all the patients, and exclusion criteria, those who are not included, or those who cannot tolerate the SGL2. So all the patients we have selected, or we have randomly selected, they were in between the years 2002 and 2020. Demographic distribution was randomly selected, so there was no fixed rate of the gender. And when we look for the hemoglobin H1C, renal function, liver profile, and prior to that, the baseline, and later all of these factors were looked. eGFR also was calculated by the MDRD eGFR calculator, and all the data was analyzed in the Microsoft Excel. Next slide, please. So our gender distribution, as I said, is not equally distributed. It is randomly, and we found that 61% we have a male, and we have a female of 39%. Next slide, please. And the age distribution, so most common and the most common and the median age was 70 to 74%. Some 18% was the most likely, and the second was 17 of the number out of 75 was 60 to 64, and the rest of you can see the other age group they were present. The next group. The next slide. And similarly, the age distribution in the range is almost same slide. Then we can go to the next slide, please. Yeah, next slide, please. So here, those patients who are on 75 of the patients, most common on SGL2 was canagliflozin. So the 35%, the 35 patients, or that was 47% was on canagliflozin, and the empagliflozin was 18 patients and 24%. And the dapagliflozin was 21%. That was 28% patients. The most least was the R2-gliflozin was the least, only one patient. Next patient, next slide. There are few combinations, as we mentioned. So the patients was on canagliflozin and metformin. There are 11 patients, and Synjardia, that is empagliflozin and metformin, was 7, and 4 were with dapagliflozin and metformin. Next slide. As we mentioned, when we looked for these patients, or they are on other medications, the most common medication was metformin to 19. And we have found that 63% all patients have with the combination with metformin, and 42 patient DPP4, and GLP-1 was 31, and sulfonylurea was 22, and insulin 22 patients. So similarly, these are the distribution of other antidiabetic drugs on these patients. Next slide. All these patients, they have other comorbidities, and they are different. They were hypertensive, and they have the different drugs according to the indications. And similarly, we found that these patients have most common drug which they were prescribed was statin on 70% of the patients, and aspirin was 50%, then AC inhibitor was 44%, DOAC was 8%, and the antihypertensive was 27%, ARB, beta blockers, and other BP medications. Next slide, please. And as I mentioned, there are a lot of other previous medical problems, and the most commonly and most related to the diabetes, we found these patients have 59% of the patients have hypertension, and the neuropathy in 51% of the patients. Similarly, hyperlipidemia was 31%. And then the rest are related to the ischemic heart, TIAs, and the foot ulcers was 12%. So all they are, we can see that all they are related to the complications of the diabetes. Next slide. So baseline. So baseline hemoglobin H1C, which we measure, and we look for carefully the data of all the patients. We have all the data, but specifically, I will more emphasize on at moment here on the hemoglobin H1C. So all the positive differences, they are important. The negative means that they doesn't shows the improvement. So you can see from 90 to 72 and 50 to all 18, 6, 25, all the positive, they have shown the good improvement in the hemoglobin H1C on these patients. So these are the maximum patients I have collected, but they are not all. The next slide, please. So here is a mean average which we measured. So at the baseline we can say 71 to 72 hemoglobin H1C, and it had, after the introducing of the SGL2, it has dropped to 67%. So there is a drop but it's not very significant, not very big drop, but there's a 5 millimole of the drop in these patients, those who have started with the SGL2. The next slide, please. So this is eGFR. Similarly, here is a difference in the minus is important. So those who have minus means they have shown the deterioration. So any patients who have SGL2 before was 90 and then later has dropped, so it has shown that there is a difference in the so those who are at minus are important. So we can see there are few of them, they have been deteriorated. Okay, we go to the next slide, please. So here is the baseline average, mean average, which we, in the summary of these, all the data which we have collected. So if we go, is a baseline eGFR in these patients was 81%, and then before starting, so it is almost 81 and 79, and it has after all the patients which we calculated, the mean is 78. So I would say it's not a big drop after the introducing, which we are expecting that the SGL2 will affect the kidney, and there will be a significant drop, which we didn't find in these patients. And similarly, we didn't require any dose adjustment in these patients. The next slide, please. So what we have concluded as we looked the multiple factor while these patients are diabetic too, they are on type 2 diabetes with multiple comorbidities and multiple medications. We looked carefully on the two factor, either these patients having an eGFR dropped after the commencement of the SGL2, or the hemoglobin H1C will drop further. So what we have found that there is a improvement in the hemoglobin H1C, which is a 5 millimole from 72 millimole to 67, which has shows its effect of hemoglobin H1C, introducing the hemoglobin H1C and improvement in the diabetic control. In regards to eGFR of the patient, the baseline was 81 and it has dropped to 78. There is no big deterioration, but there is a deterioration. So either it is because of the progression of the disease or because of the drug effect. We can't say exactly. Go to the next slide. The next slide, please. Yeah. So what we have concluded, possibly either the SGL2 is causing this deterioration in the renal deterioration, or it is a disease progression. Is very difficult to say because many patients deteriorate with the passage of the time. We didn't require any dose adjustment with this small drop of the eGFR. So we didn't commence any dose adjustment. We have several limitations in our studies. The numbers was not big enough. Probably if it is 75, I would say if it's more than 100 or around bigger sample of we might having a good result or better result in the future study that could be considered. The male and female distributions was not equally distributed, so we can't comment on that. Also some patients have started drugs a long time, which was on SGL2, and some patient has recently started. So this is also, there is a discrepancies in this also when we select studies. So these are the few factors we keep in mind while we are studying this project. Next slide, please. So in the last, probably I would say SGL2 is a good drug, most commonly used in the diabetic medication and treatment. Our studies have shown a good effect of the glycemic control in diabetic patient, and along with a combination with metformin, there is a slight deterioration in the renal function, which was not very significant to warrant a dose adjustment of the SGL2. and this deterioration may be the diabetic progression or other medications related. So thank you very much. If anyone has a question, please go ahead.
Any questions?
Yeah, I would like to kind of comment on this. So this is interesting that you did worry about the EGFR, and as I was mentioning, actually, the numbers for A1C don't tell the whole story, and so there is a nephropathy possible even if the A1C has been well contained, because the damage may not be due to just hyperglycemia. And so by adding SGLT2s and penalizing renal function even more can accelerate nephropathy in some way. So a long-term study is required on this for sure, and with a good pool with everything. And I don't know if you had looked at the cardiac aspects, and I don't know if they are overrated as well in terms of the benefits.
Thanks, Dr. Ravi, for your comments. You are absolutely right. It has a good effect on the cardiology, but probably I at that point I don't want to extend my project, because in that point, if I look for the cardiology aspect, so I have to go for the echo and the rest and see how the patient improve with the diuretic effect of the SGL2. But I know there is a latest journals which is published for the SGL2, which has shown a good effect in the cardiovascular people or the patients. So it is proven. In regards to what you mentioned, still as I mentioned, there is a risk in the SGL2 of deterioration, but we need a bigger study to find out either it is with the disease progression or it is because of the drug. Still, we are not 100% sure, but our study shows that even these patients who are long time with the SGL2 has not warned the further dose adjustment despite they are using for the long time.
All right. Okay. Anyway, I'm in general, as per my talk, I think the excessive focus on hyperglycemia is throwing a lot of other issues under the rug. And so I just think that it is important for clinicians to start thinking about this in a different perspective.
Absolutely. Absolutely. Thank you very much.
Thank you.
Yes, thank you. Thank you very much, Doctor. Thank you so much. We enjoyed your speech. Please with your topic. Looking forward to meet you again next time.
Thank you very much.
So we have left 2 more talks. Unfortunately, they are not going to join the event, sir. So it's finally day 2 of the conference is going to over. So finally, we thank this opportunity to extend our most sincere thanks to all keynote speakers, plenary speakers, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support of operation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have received several papers which will inform the basis of our discussion in these various sessions. Let us thank all the associated with the conference by your presence. An event of this dimension cannot happen overnight. It requires meticulous planning and execution and an eye of details. A special thank to Program Manager Ms. Isahan for her continuous effort in putting us all together and to join this online event. We extend our appreciation for each other for your participation in this conference. So we hope to see you all in physical event in 2021 if everything goes well. We will send you the e-certificate as well as e-book through email officially. Thank you again. Thank you for joining and for your attention.
Thank you very much.
Thank you very much.
Can I extend my gratefulness and thanks to the organizing committee and to all the participants and the speakers in this interesting conference. Inshallah, we see you in the near future.
Thank you. Thank you very much.
And goodbye and thanks to all.
And
Dr.
thank you.
Dr. Muhammad
Thank you.
Jamil Al-Habbad.
Yes, thank you very much, sir, Dr. Ravi. You have asked number of questions during this event.
Thank you.
Thank you. As well as Dr. Shakil Hamad, Dr. Naresh. Thank you very much, sir.
Thank you very much.
Thank you.
Hope everything goes well. This, if you overcome this COVID-19, we may join in 2021 as in physical event.
Yeah, definitely. We would like to.
Yes. Thank you very much. Sir. Have a nice day.
Next year.
Bye. Bye. Bye.
Bye. Bye.
Bye all. Thank you. Bye-bye.
Bye-bye. Thank you very much.
Thursday.
So just for one more talk, just now we got information from Dr. Vinindra M. Parvar from LM College of Pharmacy from India is going to deliver his talk, sir. Just now we got a message from him.
టెన్షన్ ఏం లేదు టెన్షన్ ఏం లేదు చెప్పారంటే ఓకే అమ్మ మాకేం బాగలేదు
Join it there and sorry for the participants. We have got interrupted. He is not going to join the event, sir. Thank you very much, doctor, for all the participants. We are going to close the event. Thank you very much.